So talking about pediatrics, if we're talking about pediatrics, who are we talking about? Just tell me. Who are we talking about? If we're talking about peds. Holler it out, come on. Babies, kids, right? So we're talking about the younger demographics. So one thing to keep in mind, we do not want to just treat these people like small adults, because they're not. Okay, their body functions a little bit differently, and we'll kind of go through the changes, and then depending on the development and how far along they are as they grow, will change what they're available or able to do. Okay, so for us, remember, children differ anatomically, physically, and emotionally from adults, right? Once again, don't just treat them like small adults. They do have their differences. Illnesses and injuries that children sustain and the responses to them vary based on age or their developmental level, which we will also talk more about. And then important to remember, children are not small adults. I already hit on that. And then fear of EMS providers and pain can make them difficult to assess. How do kids normally react if you're thinking, just putting yourself, maybe when you were a kid, you go to the doctor's office, right? And you know you're getting a shot. No one wants to be there, right? The kids don't want to be there. And if they've had bad past medical experiences already with providers, that's going to be further pushing that they don't want to be there. And so that's going to have some withdrawal when it comes to us assessing them as well, okay? Now, once you learn how to approach children of different ages and what to expect while caring for them, you'll find that treating children also offers some special rewards. These are the ones that provide the feel good. Inversely, these are the type of calls that can really take people into a kind of a dark place in their head. These are the ones that kind of mess people up. So on my high horse for a second, if something bothers you enough or it's bothering you in your outside life, maybe go and talk to somebody. This job's not worth your life or your brain, okay? Before we get too far, does anyone have children in here? Okay, I'm assuming you guys are together. That would make sense. Okay, so some of this stuff might feel familiar to you guys. For those of you who do not, welcome to the learning curve. So, communication with the patient and the family. Remember, we're dealing with minors under the age of 18. So these people do not make their own decisions, okay? So now we have to loop in another factor. We have to keep parents in mind, okay? They need to be involved in the care. So when caring for a ped, you must care for parents or caregivers as well. You guys will come to find that the calmer you keep mom and dad, the calmer that scene stays, the more manageable and easily manageable it is for you, okay? A calm parent usually results in a calm child, and then remain calm for yourself, efficient professional, and sensitive, okay? We bring the calm to the storm. When things are looking bad, we're the ones they call, right? This is now the moment of, we can't just say call 911 because we are 911. We are here to bring some sort of calm to this situation. Even if the situation's terrible, you have to be the level-headed one on scene, okay? And if you think about parents get spun up pretty quickly. Okay, so just keep that in mind. Now, we're gonna go through the different development stages and ages, and I'll talk a little bit as we get to like vital signs. It's gonna be a little more specific, but I'll touch on these now and then we'll go into a little more depth. So, many physical and emotional changes occur during childhood, right? So from birth to 18, you're definitely not the same person, with the stages being laid out: infancy, toddler, preschool age, school age, and then adolescent. Okay, so infancy is the first year of life, toddler 1 to 3, preschool 3 to 6, 6 to 12 is grade school, and then adolescent is 12 to 18. Now there's one on here that's not mentioned, and it's actually before infancy. Can somebody tell me what a baby is called in their first month of life? Starts with an N. A neonate. Did you say that? Well, loud and proud, man. But yeah, neonates. Neonates are the brand new babies, okay? So we'll touch on them pretty quickly. So infancy, once again, defined as the first year of life, with the first month after being born being the neonatal period, okay, or newborn period. 0 to 2 months, if we're talking about activity levels, all they do is eat, poop, and sleep. It's a pretty repeating trend. You will be seeing this a lot, but now we can start thinking about questions involved, right? If we're talking about eat, poop, sleep, that's all they do. Well, how are they eating? How are they pooping? How many diapers are they going through a day? Are they peeing, right? Like there's so many questions that we can start involving when we're talking about specific age groups. Now, they also respond mainly to physical stimuli. Has anyone ever seen the reflex, the startle reflex in babies? Right, if you like say something loud or move and their arms go out really big to catch themselves, right? You'll see that quite a bit through here. And then they cannot tell the difference between parents and strangers. They do not have that recognition yet. Because fun fact, their vision barely works. They can see black and white specks, essentially, or dots. They have no crisp vision there. And then, like we think about with all babies, their main mode of expressing themselves is crying. Okay, so for those people who have been parents, I'm sure you're aware as well that certain cries are not all the same, right? There are distinct cries depending on the need, but that's something that takes being around that kid, right? So this is where, once again, parents can become a very important lifeline for us. Is this normal for them? Have they ever had anything like this before? What would you think is going on with this? Because more often than not, we get called for these babies. Hey, they won't stop crying. I can't figure out what's going on, which you'll hear me say a bunch of times. An inconsolable baby or inconsolable child is an indicator something's wrong, okay? So keep that in mind. Trust parents' judgment. They're not just calling you because the baby's crying, right? There's something deeper going on more often than not. Once again, inconsolable infant could be a sign of significant illness. You're going to hear me say that probably 100 times today. So if I say an inconsolable infant, you should already know means something else is going on, okay? And then predisposed to hypothermia. Yeah, if we think about kids, their surface area is a little bit thrown off. They got big heads, right, compared to the rest of their body. Well, we lose a lot of heat through our head, okay? Another thing about kids is that they don't have the fat reserves on their body that adults do. So they're not as well insulated, so they get cold a lot quicker. Okay, so we got to make sure babies are wrapped. If we're going to be transporting, we got to make sure we're keeping them warm. Okay. Now moving into the 2 to 6 month range, this is where things start to change. They start to become more active. Okay. Also at this point, they start to have some vision development. They can start to look around. They're pretty distracted by a lot of things. Okay, but they can follow objects with their eyes. Once again, persistent crying, irritability, or lack of eye contact can be an indicator of serious illness. Okay, if these kids are just inconsolable, most parents are good at consoling their child to a point, right? Figuring out what's going on. If that child, they've run through that checklist and that kid is still upset, we got to start figuring out. This is where we come in deep dive. Depressed mental state can show up, or delay in development. I'll come back to that one, but depressed mental state, can we ask babies questions? No. Once again, parents are our lifeline. Okay, ask the parents, is this normal or not? They're going to tell you. And then delay in development, depending on what the cause is, that might be something that shows up later, or they might already know. Okay, there are a lot of blood draws, blood tests the doctors can run while the mother is pregnant that can actually tell them if they have some sort of developmental delay, things like Down syndrome, so on and so forth. Okay, if you see that's the case, right? Ask the questions. You can ask, well, let's talk about this. What's something we could ask mom and dad to see if a physical presentation is normal or not? Maybe run through a set of questions. Can babies have a medical history? Yeah, right? What's their history look like? Most parents will tell you there's none, right? If they're this new to the world, 2 to 6 months, they may not have any medical conditions, but we can still ask. Right? And that's something we need to make sure we're asking, otherwise we're missing things, okay? Moving to 6 to 12 months, still within that first year of life, this is where they start to become mobile, things get a little bit hairier, right? The more mobile they are, the higher risk of physical danger they're in, right? Which kind of makes sense from like a statistic math perspective. People who fall down the most have a high likelihood of injury. People who are moving and running around have a high likelihood of injury. This is where we start to introduce that concept in our lives, okay? This is also the stage where everything goes in their mouth, okay? Kids will use their mouth kind of as their eyes to see the world. Textures, things like that. They're starting to figure it out, and the only way for them to find out is to put it in their mouth. Well, we get called for chokings and things like that, or pills, right? People keep their medications or illicit substances out and about. Kids just roaming around, who knows what they're getting into, okay? They've also at this point started to develop what is called object permanence, okay? So they can essentially, just because they don't see mom and dad, they know mom and dad are still there, right? Which it truly develops a little later, but this is where it starts, okay? If they're separated from parents or caregivers, they recognize mom and dad. Okay, so this is another thing. If we're dealing with a really upset baby and we are trying to get an assessment, should we take them from mom and dad and hold them ourselves? No, not always. Sometimes the kid will be open to it, and that's fine. If that works, that works. But if if you pull them away from mom and dad and they get really upset, give them back, do our assessment in their arms, okay? Make our lives easy. And then once again, persistent crying and irritability, probably a sign that something's going on, okay? Have I nailed that concept in well enough at this point? Okay. So moving forward for our assessment. With infants, the nice thing is it's not that we won't get hands-on, but we don't really need to as much. And we'll talk about the assessment triangle here in a bit when it comes to kids, okay? But the nice thing is we can observe them from a distance. We can tell how they're breathing, we can tell their activity, we can tell their color from a few feet away, okay? Also going back to it, the caregiver should hold the patient. Make them calm. The calmer the patient is, the better we can do our job, okay? This is kind of a pro tip, provide sensory comfort. We deal with all weather types in the ambulance, on the fire engine, right? Your apparatus is gonna be the temperature of your vehicle. So if it's 14 degrees outside and you haven't touched that pediatric stethoscope all day, it's probably gonna be cold. Try to warm it up a little bit. If your hands are cold, warm your hands up, okay? And then last but not least, if you're gonna do painful procedures, for you guys, the big one, BG checks, right? We gotta poke the finger, get some blood, or with kids, we'll poke their heel. Try to save it for the end. Because if you don't, you're gonna kind of start off, they're not gonna trust you early. You cause them to be in pain. They don't wanna let you finish an assessment at that point, okay? Questions on infants at all? Okay, sorry, moving on. So now we're in the toddler age, so 1 to 3, okay? Rapid changes in growth and development. This is when kids become, just a weird description, but kind of units of people, right? They're small, they're bulky, they're strong, they're meant for falling down, okay? Experience rapid changes and growth, and at this point, they're also mobile for the most part. Most kids will start walking around the 1 year mark or so. Okay, so 12 to 18, they're gonna be explorers, 18 months, they're gonna be explorers by nature, not afraid. They haven't had the life experience yet to figure out what to be afraid of, okay? Now, another thing, they lack molars, so they can't chew their food. So once again, choking is a big risk. And usually around the 6-month mark is when solid foods are introduced to babies. Okay, so choking is a potential. So yeah, choking hazard, very real with these kids. And once again, with explorers, they're not sure what's gonna be the painful stimulus. They've never been into certain things. And so the reactions are gonna be a little bit different. Now, once again, our assessment is still gonna change from our normal adult assessment. They may have some stranger anxiety. At this point, they recognize mom and dad. They can see, they're looking around. If they don't know you, not every kid's comfortable with you, okay? They may resist separation, so maybe we have mom and dad hold them. Obviously might have a hard time describing the pain. Their development is not quite there. Can be easily distracted. That's something that actually works in our favor. Most ambulances will carry some sort of stuffed animal or some sort of toy that you can use to give to the child as a, hey, look over here while I do what I have to do over here, okay? This is also where we got to start beginning our assessment at the feet, okay? We start low and work high. Think about if somebody's scared of you and the first thing you do is reach for their face, they're probably gonna panic a little bit. Start low, build comfort working up, okay? Persistent crying, I'm not gonna go into it again. And this is also the age where they might have previous medical experiences. They might start to remember. Usually by this point in time, kids have started getting vaccines. So they're gonna know what the needles are. They're gonna know that that's not friendly. They may not know exactly what it is, but I'd argue most adults don't know exactly what it is either, right? But they are gonna be familiar with the needles at that point. So keep that in mind. They're gonna recognize painful stimuli if they have the memory of it. Questions on toddlers? Okay. So preschool, 3 to 6, this is where they're going to, for sure, have experienced some degree of pain in their life, okay? So there's high chance of fear of pain, and they also have a rich imagination, which is something we can play into, okay? Kind of going off this bullet, may believe injury is a result of earlier bad behavior. We want to nip that, right? That's not for us to, I don't want to say endorse, but endorse for the parents, right? Or that's not up to us to tell them that. And honestly, it's probably better to give them a reality check a little bit, but I digress. So another part, continuing on foreign body aspiration, right? We've all seen how kids eat, kids play, right? Go and take 4 bites of their food and then run off at a barbecue, right? Continue playing around the backyard. Choking hazards are still very, very real, okay? But going to the imagination, we can use that to our advantage. I had one partner in particular kind of a hard-nosed guy. He got along well with most people. Some people he definitely did not, but I watched him interact with kids, and watching that guy 180 was really impressive. He would go from being this kind of big, kind of scary looking dude to, do you like Frozen? Who's your favorite character, right? And they can start building that rapport early by going with things that the kid's aware of, right? So use that to your advantage. For our assessment, so can understand directions, specific in describing painful areas. Depending on the age, right, 3 to 6 is quite the range. But depending on the development of the child, they could tell you what's going on, what's hurting. What does it feel like? Is it hot? Does it sting, right? Is it sharp, right? We can maybe start getting into that. At this point in time, they should have some degree of history, whether the history is they've been evaluated and there is none, or we'll kind of know what's going on, okay? At this point, they also can communicate directly to us. Don't just bypass them and start talking to mom and dad. We can start asking them questions, okay? Depending on the scenario. If there's situations, where they're scared, they're gonna clam up a little bit, and that's fine. We can go for mom and dad. But if we can build rapport, which is so important with every patient we run, okay, but if we build that rapport, they might come and talk to us directly. And we can get more information straight from the source rather than trying to bypass through mom and dad, okay? And then going back, appeal to their imagination, right? That can help us with our exam. Now, this next point, I'm glad it came up early. Don't lie to kids. Kids are really, really good at reading the micro expressions on your face, okay? They're gonna weed right through that very, very quickly. Don't lie to them. Okay, now if it's something above their knowledge base, we gotta obviously leverage mom and dad, but don't just bold-faced lie to a kid, because they're for sure gonna read through it, and then there goes that rapport you spent so much time building, okay? And it's a really easy thing to destroy. Once again, easily distracted. Our assessment's still gonna start at the feet, move to the head. Use adhesive bandages or Band-Aids to cover the site of the injection or small wound. A lot of ambulances will carry specific Band-Aids for kids, just the ones with pictures on them and stuff like that, just so it's a kind of a comfort bringer, even though it's not really going to do much. And then this is also where they're gonna start becoming aware of their own bodies a little bit more. So the more modest we can keep them, right? Keep them covered. We don't need naked babies running around all the time, okay? Keep them covered as much as you possibly can, just for their own psyche. Questions on preschool at all? Okay, so school age 6 to 12, this is definitely where they start to emulate their surroundings, right? They'll begin to act more like adults. We can start talking to them a little bit more directly, even further so than we were before. So they think in concrete terms, can respond sensibly to questions, and they can help take care of themselves. This is something where, I just want to see, we'll talk about in the assessment, but you can actually utilize them in their own care a little bit by giving them jobs, and I'll talk about that. School is also going to be important to these kids. Even if school is something that's not important to you, think about it from their perspective. This is their opportunity to be social. Kids are little sponges for information. Don't kind of destroy the dreams that school matters to them, okay? School is important to these kids, and we don't want to break that up too much. This is also the age that children will begin to understand death, right? The idea of permanence when it comes to death. A lot of kids, I'm sure some of us in here can even think to elementary school where we've had a family member pass away, grandma, grandpa, great-grandparents, right? You start to put 2 and 2 together, okay? They start to have the understanding, or they had the dead fish situation, right? So a lot of them will have fear of death depending on the scenario. So once again, our assessment begins more like adults. This is where we can start to move to the head, work our way down. Okay, so 6 to 12, when they're more of the ability to talk to us, they have that age range to talk to us and become a part of the actual engagement there. Okay, so help gain trust, talk to the child, not just the caregiver, like we talked about. Okay, start with the head, move down, so we're gonna flip-flop. Now, this is where we can give the kid choices. And honestly, choices are great for all of your patients. If you give people options, they tend to follow through a lot easier, or they tend to feel involved with their care and they'll comply with what we're asking them to do, okay? Ask only type of questions that you can control the answer. So it's the same thing with our person, place, time event, right? We wanna know the answer to the question we're asking. That's why asking what's your name is not always the strongest one, because if someone's altered and we're like, what's your name? And they say John. And then we look at their wife who's like, that's not his name, right? We know for sure we can't verify that unless we have some sort of ID. So ask questions that you know the answer to, and then don't argue with them, don't debate with them, especially the kids. It's not worth your time or your anger because you will not win all of them. Because it doesn't matter how many good points you make, kids are going to find a way to disagree with you, promise. Now, this is what I was coming back to, what I was saying about giving them a job. Allow the child to listen to their own heartbeat through the stethoscope, right? Hey, can you hold that blood pressure cuff on for me? Hey, can you put this on your finger? Can you put this on that finger? Put it on your toe, right? Give them something to do. It's that distraction, and it kind of works for our favor, right? Because if they're distracted over here, we can once again continue to assess over here, okay? They also understand the difference between physical and emotional pain at this point, so read the cues. And if, depending on their development, depending on how our rapport is built and how they're talking, this is going to be one of the times where we can explain what's going on, okay? They might have the understanding of, hey, your arm hurts because you fell off the monkey bars and I think it's broken, right? We can actually start talking to them like that. Now, don't be surprised if that ramps them up a little bit, but depending on the patient, depending on the circumstance, it might help, okay? And then ask the parent or caregiver's advice about which distraction will work best. Mom and dad know. What's the best way to distract them, which, let's be honest, nowadays is like an iPad or a phone, but same time, they're going to be able to work through that with us. Okay, well then can you get whatever Netflix show up on your phone real quick while I do this? Right, parents can help out with this. And most of them, especially in moments of high stress for their kid, don't have an issue with it. Okay, questions on school age at all? Okay, before we move into adolescence, one other thing I want to talk to you guys about, just as a recognition of what you're actually doing. Think about the job that you want, and think about other just random business jobs, right? Random other professions. Not many of those professions will somebody walk up to you with a sick or dying child and say, here you go, right? Kind of take the gravity of that moment into check for a second, right? This is a profession where we are inherently trusted, so do your best to get through these situations and provide the best care we can, okay? It doesn't matter how many calls you've ran on the day, how tired you are. This is especially the ones that we need to do our best at, okay? Now moving on. Adolescents, 13 to 18, physically similar to adults. This is also where puberty begins, right? So modesty is gonna be a big thing, right? They're gonna be worried about their own image and appearance. They're gonna have feelings about privacy. They're developing who they are in their mind, okay? This is also where they're gonna be risk takers, right? They're gonna have that indestructible or invincible mentality, like I'm sure we've all had at one degree or another. It can't hurt me, right? It won't happen to me. It does, okay? This is also gonna be the part of their life where they start to really struggle with independence, right? 15, 16, I got a car I can drive. Mom and dad still tell me what to do, right? They're gonna have that kind of back and forth. Loss of control, right? They just don't feel like they control their own life. Body image, sexuality, peer pressure, all of these things start to kind of cascade in this time of life for these folks, okay? Which I'll come back to something else that's on my mind with this. But anyway, assessment can often, with these people, we can keep them in the loop. They're old enough where they understand. Usually, right around that 16, 17 is where we can really have kind of blunt conversation about what's going on. Okay, they also respond better to options. Once again, treatment options. So allow them to be involved in their own care, right? Provide them choices while lending guidance. Hey, this is what I think's going on. A spiel I used to commonly give. Got a few choices here. You can either come with me, you can have mom and dad take you, or if mom and dad don't want you to go at all, they don't have to. But those are the three options I can give you. And usually if you give them three choices out of all of them, they're gonna pick one or the other, right? So it kind of helps guide our own treatment. But obviously mom and dad are gonna have the end all be all say. And then if we can, have the same gender line up for the assessment. Now, anytime we see this bullet on any of our slides, it's if possible, right? We can't always control if it's a male-male ambulance or a female-female or a male-female ambulance. It really just depends. Now, if this is a situation where it's male-male and it's a female patient, you're gonna have to be professional, okay? Be respectful with the whole thing. Because at the end of the day, I'm likely not going to call for another ambulance because I cannot guarantee the ambulance showing up is gonna have a female on it, right? It just depends on who's available in the areas. Now, if you know for sure and they're not that far, maybe, right? But for the most part, if possible, try to have the genders line up. It'll go a long way. This is also an opportunity for you guys to protect each other, protect your coworkers, right? Get put in a kind of a dicey situation. I've seen it happen more than once, okay? Where people are yelling, making accusations of things that are not happening. Protect each other. Because remember, end of the day, you guys are stuck together, whether you like it or not. Allow these patients to speak openly, ask questions. They're gonna have plenty of questions. And then once again, going back to risk-taking behaviors being common. Now, can ultimately facilitate development and judgment, helps to shape identity. I'm sure everyone in here can think of one story off the top of their mind was like, well, that was dumb, should probably never do that again, right? Learned our lesson because of risk-taking behaviors. It's kind of molding them to who they're gonna be. Now, don't be judgmental, right? Like, kids do stupid things. Kids jump off third-story buildings because they think they can land just fine and roll into it. Don't be too judgmental, right? Work your way through it as best you can. So trauma, dangerous sexual practices, and teen pregnancy start to really show up. We'll talk more about pregnancy on Wednesday when we cover OB. Okay, but this is where also teenage pregnancy is very, very real. We're in the United States, we're really good at this. We got like 6 TV shows or something about it, right? Teen moms, there are a whole bunch out there. Keep that in mind. Now, female patients may be pregnant. Adolescent may not want their parents to know this information. This is kind of a gray area, and I'll come back to it. Now, try to interview without the caregiver or parent present. Have a clear understanding of pain, so remember, they're gonna know what's going on. Keep them involved with their care. And then if you have to, get them talking about something not related, get them distracted so that we can hone into what we actually have to. If we have to take a roundabout loop to get the information, that's still the information gleaned, right? Now, coming back to the pregnancy thing. This is not our information to give, okay? Mom and dad are gonna find out one way or the other. 9 months down the road, they're gonna know, right? This is where we kind of put ourselves in gray areas. So this is one where see what your department wants to do. This is a medical control call. Never goes wrong with a good medical control call. Remember, someone above your pay grade making choices. But as far as we are concerned, per my training, we do not disclose this information because it's patient privacy at that point. This is where minor law gets kind of tricky. Okay, so double check with your department. Now, as far as interviewing the caregiver, let's say we have a potential pregnant, I don't know, making it up, 16-year-old, right? Well, we want to ask blunt, open questions because do you think a 16-year-old girl is going to talk about her sexual history in front of her parents? Probably not, right? We need to get as much information as we can. So what I would do historically is I've had parents or a fire captain be like, hey, can you take parents over there and fill out the paperwork? I'm going to talk here. Or if we're in another room, I would go into the room with the patient. We would close the door and I would make sure I had someone standing right there with the door cracked, okay? Why do you think I have someone standing on the outside? Just make sure while I'm in there with the patient. Why would I do that? Protect myself, exactly. Accusations are made all the time, right? This is just another form of CYA, cover your ass, right? Where you can basically, if there's yelling and accusations, someone can be right there and either disprove that or, hope to God not, right, prove it. But keep that in mind, protect yourselves there. If you gotta have an honest conversation, another place you can go is just take them to the ambulance, right? That's our office. We can have a conversation in the office, okay? But just keep in mind, if mom and dad are around, we are not going to be able to get a thorough history, especially if it's involving things like pregnancy, okay? Now, one other thing with adolescents that gets tricky. Has anyone ever seen a 17-year-old boy who looks like a grown-ass man? Yeah, right? There's a line to where we treat people like adults versus we treat them like kids. And that line is presence of puberty. Okay, so in boys, voice change, underarm hair. In girls, it'll be breast tissue development, okay, also underarm hair, okay? But we need to find those signs. If we don't, that helps to, rather rephrasing, that helps us delineate, is this an adult versus a pediatric? And it can be really tough sometimes, okay? An example, my wife ran a call for a kid who got hit by a car on his scooter, ended up being a fatality. My wife on scene thought this kid was 14, big kid. Turns out he was just a really big 10-year-old, right? Sometimes it's really, really tough. Different demographics grow differently. Different demographics mature differently. Just keep that in mind, okay? Questions at all on adolescence? A lot of gray area here, okay. Okay, so some A&P stuff. So Obviously the body's gonna change at each one of those intervals there, but the whole thing throughout is the body is changing very rapidly, right? They're going from literally this big to walking, talking people. Okay, so there's a lot of growth that's gonna go on very quickly. Now for us, we need to understand the physical differences between children and adults because our care will change, okay? So kind of going into the respiratory system, that's a perfect segue. The anatomy of the airway is different from an adult's. Kids tend to be more anterior, more towards the front, okay? They also have a smaller airway, okay? Both in diameter, so it's narrower, and it's shorter, right? Because they don't have to go as far to their lungs. On top of that, their lungs are smaller. So should we be squeezing that bag full every single time? No. Does anyone know, just in the average adult, what the normal tidal volume is? How much air should we be delivering, roughly? What was it? About 500 is the average. Yeah, 500 mils is an adult, right? So we're not gonna need 500 for this child at the top, okay? On top of it, their heart is higher up in their chest. So if we're gonna go listen to lung sounds, if we're listening to heart tones, we gotta adjust accordingly, okay? Another thing is that kids have big occipits. The back of their head is large, okay? So if I was to lay a kid down on the floor with the big back of the head, they're naturally gonna do this. Is this an open airway? No, okay? So one thing I want you to write down, when we are dealing with a child, usually I would say anywhere from toddler to about school age, we need to pad under their shoulders with a rolled up towel, roughly an inch of elevation. Children from toddler to school age need a towel rolled under their shoulders about an inch in elevation. That's going to bring the chest forward, head back, open that airway. Because remember, the airway sits in the front, it's more anterior. Okay? Questions on that at all? Okay, moving forward. Now, the glottic opening, right? Their vocal cords. It's higher, positioned more anteriorly, right? So the neck appears to be non-existent. If you've ever been around babies, it looks like they got a big old head that sits on their shoulders, and it's not until they turn their head or lift their head up that you see their neck, right? Keep that in mind. Still have to manage that airway. As the child develops, the neck becomes proportionally longer as the vocal cords and epiglottis achieve anatomically correct adult position. So as it changes, your voice changes, throat gets longer, okay? I want to go back to one other thing, or think about one other thing. OPAs. Should we put OPAs in the same way we put them in adults? Is there anything saying we can't? Let's think about it. So another thing is that kids have larger tongues. Okay, so we already talked about the rounder occiput. Kids have larger tongues. So the choking hazard on their own tongue is a lot higher, right? It's an odds game, once again. There's a couple of actions we have to do that's far different than with adults. You will take a tongue blade, tongue depressor. You're gonna hold that tongue down, get it out of the way. The next thing, if we're inserting an OPA into an adult, what do we normally do? Do we just shove it straight in, or what do? We rotate it, right? We want to avoid rotating with kids. Hold the tongue down and you're gonna follow the natural curvature of their mouth. Reason being is that that tissue is underdeveloped. It's not quite ready for the same maintenance as an adult's. Okay, so if we twist that, we run the risk of damaging the roof of their mouth, damaging their gums, their cheeks, right? Straight insertion. So tongue blade, hold the tongue down, straight through. Everybody feel like they got that difference. Okay. Their epiglottis is different. It's long, floppy. I've often heard it described as omega shaped too. So it's got more of like an O shape to it. It's not as narrow. Okay, and that'll come into play when we talk about an illness down the road here. Their tracheal rings are less developed in the trachea. So they have a high likelihood or higher likelihood of damaging their throat if there's contact compared to an adult. It's not as resilient, okay? And then the upper airway is funnel shaped. Remember, they have a small trachea, short, narrow trachea. So their whole head is designed to bring air into that trachea. So it's gonna be kind of funnel shaped there. I've already talked about it, but for infants, the diameter of their trachea is about a drinking straw. We don't have a lot of wiggle room with that, okay? Got to maintain that airway. That's where keeping those shoulders padded is so important, because if we don't, we're kinking off a straw, okay? that they're not gonna be able to breathe through. Another thing is that airways easily obstructed with secretions, blood or swelling, small airway, increased likelihood. Infants are nose breathers and are gonna require suctioning and airway maintenance. Now, from a suction perspective, out of all the holes on our face, which one brings in more air, our nose or our mouth? Per breath, which one could we bring in more air, you think? Quicker, I'll rephrase. Nobody? What's the fastest way to get a bunch of air in your lungs? Through your mouth, right? Through your mouth. So don't be surprised if with infants, we gotta suction their mouth quickly. Get that first. Give them the biggest opportunity to get more air in, then we can work to the nostrils. The next thing is that their respiratory rate is a little different. What's the normal respiratory rate for adults? 12 to 20, right? 20 to 60s for a newborn, right? Their respiratory rate is really high. Now, you are going to be just down the road, and our EMT is likely going to expect you to know these vital signs. Okay, there's tables, commit them to memory as best you can. They are pretty different. We'll talk about cardiac here in a moment. Pretty different. For me, from a real practicing perspective, I didn't have enough brain space. I had to get rid of my 4th birthday party just to make room for my medic stuff, okay? Same time, just keep that in mind with these folks, is that you're realistically not gonna remember them forever. So for me, what I did is I found a table that I saved in my favorites on my phone. So if I was dispatched to any kid call and they had an age range, I could look it up immediately and be like, okay, I should be in this range right here, okay? Keep it realistic, because the odds of you forgetting a very minor thing, because this is not a high likelihood call, or rather, this is not a high frequency call type pediatrics, depending on where you work. So, children also have twice the oxygen demand as an adult, which if we think about it, their body's growing. If their body's growing and changing constantly, their need for oxygen, their need for perfusion is much higher, okay? So to supplement that, we have to be on top of how frequently we're bagging, how much oxygen they're giving. Because if we're not careful and we're just assuming they're gonna be like adults, they'll go into hypoxic states very, very quickly, okay? Gotta be pretty up to snuff with that one. The muscles of the diaphragm dictate the amount of air the child inspires, right? So the stronger their diaphragm, the more air they're gonna pull, okay? So if we think about it, where does our diaphragm stretch down into when we take a breath? Someone tell me. If I take a big old breath, where's my diaphragm going? Up or down? It's going down towards my abdomen, right? Has anyone ever seen, I just always imagine there's like that 1 3-year-old at like a barbecue. He's got his tummy all out, right? And he's in his diaper running around. You can see him taking those big breaths with his stomach. Kids are belly breathers, okay? We're not always watching chest rise on kids. Sometimes we're watching abdominal rise, and that's just fine, right? Just depends on the kid. But by extension, that means if we put pressure on their abdomen, they can't take a full breath. So be careful about how much pressure you're putting down on their chest, on their abdomen, because they might not be able to breathe efficiently because of what we are doing, okay? And then if we're putting straps of a spinal immobilization device on, we gotta be careful. Remember, we're never going over soft orifices, right? Or not orifice, not the right word. Soft structures, right? We're not going over the abdomen. We gotta be bony structures. Hips, thighs, chest, rib cage, right? Hold the bony structures, especially if we're thinking with kids, have them take a big deep breath and hold it as we're strapping that down. That way, when they relax and they take a breath, they're never gonna be pinched down and they can continue that breath forward, okay? If I lost anybody, does that make sense? Okay. Last one, gastric distension can interfere with movement of the diaphragm and lead to hypoventilation. If a kid's really bloated, right, for whatever reason, that's gonna affect how far their diaphragm can go. And as we know, if the diaphragm can't move, breaths are gonna suffer, okay? Another nice thing about kids though, is when it comes to actually listening to their lung sounds, it's easier to hear. One of the biggest deterrents or biggest obstructions rather, when it comes to listening to adults is adipose tissue. Well, we already talked earlier, kids don't have a lot of adipose tissue. They're not insulated as well, okay? So it's actually easier to hear their lung sounds compared to an adult. Now, when we listen to adults, where should we listen? Chest or the back? The back, right? We can listen to the chest will work, but the back is the most thorough space. Opposite with kids. Remember, their anatomy is anterior, okay? Higher up, more forward facing. So if we listen to the chest, we'll actually get better sounds, okay? And then detection of poor air movement and complete absence of breath sounds may be more difficult. Right? That's another thing, is if we're listening for 60 breaths a minute and that's a whole breath, right? Just one little, right? We might be missing stuff. So make sure you're taking the time, listening for the full 30 seconds, listening for the full minute if you're having a hard time hearing. Okay, make sure you're not missing things, because this is going to help guide our care. Questions on the respiratory system at all with kids? Okay. Moving forward, circulatory system. So important to know their pulse ranges, which there's a table here we'll talk about. Infant heart beats can be about 160 or more. Okay, 160 per minute or more. Now, nice thing, I don't know if I like the phrasing of that. Children are better at compensating than adults, right? When we talk about compensatory shock, compensatory mechanisms, kids do a better job. Now, when it comes to adult versus child compensation, adults is more of a bell curve. So they're not doing well, or excuse me, they compensate, and then it's a slow slope down to decomposition, eventually death, right? Kids are a little bit different. Remember, they compensate really well. So if they're bell curve, they go, oh, compensate, but when they no longer can, they crash, okay? Kids do not have that nice subtle, which, you know, subtle can look different depending on the circumstance, but kids' bell curve is a lot more aggressive. They decompensate a lot faster. So we got to keep that in mind, right? We got to understand that if we do not stay up on the things we need to stay up on, as for example, perfusion-based treatments, we run the risk of them crashing a lot faster, okay? Children do shunting very well as well. So children are able to compensate for decreased perfusion by constricting the vessels of their skin. So they start moving blood from areas that are not as necessary for survival to areas that are more necessary for survival. And this can look kind of specific. I'll show you an example here in just a moment. Now, as far as signs of vasoconstriction, we know they're shunting, something's not going well. What are we gonna see in their skin? Well, first things first, pale, okay, pallor, pale. Remember, blood does a couple of interesting things for our body. It gives us temperature and color. So if they're pale, that means they don't have a lot of blood perfusing through that skin. Their pulses, their distal pulses in their extremities might be weak. Okay, maybe we see delayed cap refill, cold hands or feet. Let's kind of backtrack to a topic from CPR. When it comes to babies, where should we feel a pulse? On the brachial. Why don't we want to use the carotid? Yeah, they got no neck, right? Little fat kid necks. Can't reach in there and find it, okay? So we're going off that brachial. Now, another presentation you'll see in the skin is not just pale. It's something called mottling. This is a good picture of it. You see this kind of like grid-like pattern in their skin? This is another sign that that skin is not perfusing in kids. Adults, this tends to be something more either illness-derived, sometimes cold, but with babies and kids in particular, you'll see this mottling, which means that they're starting to shunt blood, which means we got to start to figure out what's going on and why are they doing that, okay? Questions about mottling at all? Okay. Then back we go. So here's a table full of their heart rates, right? Now, once again, I'm not expecting you to have these all memorized. The better you have them, the better you'll do. But real life scenarios, like I said, I would just keep a table like this available. So as you're dispatched to an 8-year-old or a 14-year-old, you can find that pretty quickly, okay? Now notice newborns, 85 to 205, okay? We'll talk more about it on Wednesday, but we will actually start CPR on babies who have a heartbeat, okay? If it's a heart rate of 60 or less in a newborn, we have to start doing chest compressions because that's not effective enough to start perfusing and circulating blood, okay? And obviously if we don't perfuse blood, we don't survive. So keep that in mind. Questions at all on these? This table's in your book. Yes, sir.
So talking about, if you start CPR in an infant that was, 60 beats per minute, do you have to do double time?
We'll talk about the rate. It changes. Yeah, you'll have it changes to 3-to-1 ratio, actually. 3 compressions to breath. Yeah, it changes. We'll talk more about it on Wednesday, though. Okay, moving forward. So nervous system. Pediatric nervous system is immature, underdeveloped, and not well protected, right? Their head to body ratio is larger. Kids got big old domes, right? Big heads compared to their body. We lose a lot of temperature there, but the bigger something is, the higher likelihood of injury, right? And kids are top heavy. So this is gonna sound terrible. Has anyone ever seen a kid fall down and they seem to flip upside down midair, right? Top heavy, big domes. My sister is a good example of that. She's probably okay, mostly okay from what I dropped her. But yeah, just a little bit bigger, so keep that in mind. Bigger head, higher rate of injury. We talked about the occiput, the occipital region of their skull is bigger, right? So that's gonna adjust our airway management techniques. There's subarachnoid space, relatively smaller, less cushion. So injuries like coup contra coup patterns have a higher fatality rate, have a higher likelihood of long-term injury, okay? Because they don't have that buffer, they don't have that CSF circulating in their skull to act as that shock absorber, okay? And then brain tissue, cerebral vasculature, fragile, prone to bleeding from shearing forces. So things like decelerating, right? Decel injuries, if someone crashes their 40-mile-an-hour car into a tree, they come to a stop right then and there. There's a high likelihood that these kids can actually have brain bleeds just because their own anatomy is weaker, okay? This is also kind of backtracking. The subarachnoid having less cushioning, not a fun topic, but shaken baby. This is essentially just coup contra coup injury over and over and over as they shake that kid, and that kid doesn't have the shock resistance in their head yet, right, or the shock absorbing capability in their head yet, so tends to be high likelihoods of things of like long-term neurological deficits and or death, okay? Now, pediatric brain also requires higher cerebral blood flow, oxygen, and glucose. Kids' perfusion level is higher. They're growing, they need more fuel, okay? Which by extension, if there's any sort of injury, the primary injury being contact, secondary injury being kind of the developments with it, things like hypoxia or hypotension have a high likelihood of following up with this, okay? If we do not perfuse their brain, they're not gonna survive. Now, the one thing about kids is their spinal cord injuries also are less common. They don't tend to have as many spinal cord injuries, especially, dictating on the age a little bit. But little kids, when they're walking around that 3-year-old, 1 to 3 year range, they're pretty shock absorbent. They fall down a lot, right? Which, fun fact, kids that age don't have kneecaps for that very reason. They develop later, right? Because they fall down on their knees all the time. It's padded up. Now, if injured, it's more likely to be an injury to the ligaments because of a fall. Not a lot of like spinal cord damage itself, but they can hurt the surrounding structures of the back. Okay, and then for neck injury, we're still gonna do the same thing we always would do. Maintain C-spine. You will have, I don't have any over there, you will have pediatric collars that are smaller and designed to fit kids, okay? Questions at all on this? All right, let's just see where we're at. I'm gonna get through the systems and then we'll take a little break, okay? So GI, abdominal muscles are less developed, okay? They don't have that development of that strength of tissue, okay? Which then means, by extension, that the organs lying underneath those abdominal muscles have a high likelihood of injury. Okay, so liver, spleen, kidneys. On top of it, they're larger in a smaller space, okay? So prone to bleeding and injury, big organs, right? Solid organs. Are any of these hollow, liver, spleen, or kidneys? Are they hollow? What are they? Solid. So what type of shock are we likely to see with solid organ injury? Starts with an H. Hypovolemic, right? Yeah, hypovolemic, because they can bleed. And then on top of that, they have a higher risk of multiple organ damage. So if we think about, a 3-year-old's abdomen, I don't know, probably this big. If they were to get, this sounds terrible, but if they get punched in the stomach, right? It's not gonna be like an adult where it's like, oh, they hit my liver, oh, they hit my spleen. If they're hitting a small area, depending on the size of what hits them, the likelihood of that force dispersing out and hitting other organs is fairly high, okay? So organ damage, not off the table with kids, especially if you think about like things like bicycles, right? The handlebars turning, catching them in the stomach, or falls and they land on their stomach, okay? High likelihoods. A musculoskeletal system, so their bones have growth plates, right? So as a result of growth plates, children's bones are softer, more flexible, making them prone to stress fractures. Thinking back to your orthopedic chapter, what kind of fractures do kids' bones typically have? What type of fractures do kids' bones usually have? Search with its color. I'll throw that out there.
The spiral, right?
Not spiral. Green stick. Does that sound familiar? Green stick fractures. So if you think about a tree branch, right? A normal, regular tree branch you can break in half, right? Snaps, no problem. So anyone ever tried to break a green stick in half? Nobody in here has tried to break a green stick in half. Yeah, right? When you break it, it doesn't break cleanly. What does it do? Yeah, it kind of peels apart, right? So these kids tend to have the green stick fractures where they don't break clean. They don't have clean shearing forces. Most of the time they'll have an incomplete fracture because it breaks and then the fracture runs along the length of the bone, okay? And then bone length discrepancies can occur if there's an injury to the growth plate, right? So this is another one where you're going to immobilize. Has anyone ever seen somebody who's got like the one taller shoe than the other, right? Shorter leg, taller shoe. Usually that's because of a fracture to a growth plate. If that growth plate is fractured, that limb will not grow to the same extent as the other one, which nobody's legs and arms are the exact same for the most part. Always pretty close, but yeah. This is where we see those epiphyseal fractures. Epiphyseal fractures are breaking of the growth plates. Bones in infants' head are flexible and soft. Okay, remember they have soft spots. Soft spot on the top, soft spot on the back. Those are known as fontanelles, okay? Usually with babies, they usually close up within the first year, year and a half of life. Okay, will close particular stages of development. But the nice thing is fontanelles, like it says here, are a great assessment tool. You can learn a lot of information from fontanelles. We'll talk a little bit more about it on Wednesday, but if we see the soft spot in a kid's head, if it's starting to dome or it looks depressed, not domed, but inverse, depressed, concave, that can be a sign of dehydration. That can also be a sign of hypoperfusion or hypovolemia. Flipping that, if it looks like it's doming out higher than the rest of their skull, that could be an indicator of intracranial pressure, ICP building, okay? We can get a lot of information very, very quickly just based on appearances. So fontanelles are the soft spots in the top of the head, back of the head as well, they'll have two typically. And then the rib cage. The thoracic cage, highly elastic and pliable, right? Most of our rib cage as we get older is, about, let's say 75% bone, the rest of it being cartilage that connects into our sternum at the front. Okay, with kids, it's mostly cartilage. They're designed to take a little impact, right? When they're younger, they fall down a lot, so their body is resilient to that. But by extension, if that's more pliable, that means the vital organs are less protected, right? The heart, the lungs, those are less protected just because it's softer. Okay, so that force can transfer a lot easier. Okay, questions so far? Okay, last one. So pediatric system for integumentary. What does integumentary mean? What system are we talking about? You can see it on every single person in here. Their skin. Integumentary is skin, right? So already touched on it, their skin is thinner, right? So the layers aren't as developed. They also have less subcutaneous fat, so they're less insulated, meaning they get cold a lot quicker, okay? On top of that, because they don't have as thick of a skin, they tend to have deeper burns, right? They don't have to be touching the hot iron for as long to have a deeper, more severe burn, okay? So our rule of 9 ratio changes. If you have not paid attention to that, I would go back and double check your your soft tissue chapter to go over your rule of 9s because it will change with kids. The percentages differ. They also have a higher ratio of body surface to body mass, meaning they can lose more fluid quicker. They can also lose temperature quicker because the more exposure we have, the more temperature we put off. Okay? Questions on skin at all? All right, let's come back. We'll call it 9 minutes, 2:10. Okay, take a break, stand up, do what you gotta do. Okay, so per usual, I'm gonna skip through like scene size up, primary, secondary, history. I might stop on one when we get to the assessment side, I'm thinking about it, because we do need to cover this right here. So, The PAT, now remember, with infants, do we need to hold them to get an assessment done? With kiddos, no. Where do we start the assessment? At their feet, right? Start at the feet, work our way up. Now this is going to be our criteria for how we do that distance assessment, okay? The pediatric assessment triangle. So it does not require us to touch the patient, and it can be done in less than 30 seconds because in real life you're gonna get lots of information really, really fast just by paying attention. So our three categories are work of breathing, appearance, and circulation to skin. Okay, those three things we need to be paying attention to. Does not require any equipment, right? Now vital signs, obviously if we could get them, we would like them, but kids are tough. Here's the other reality is that for most kids under the age of 3, we don't often get blood pressures just because it's hard to get them around there. Hard to get that around the little arm, and then on top of it, the kid's wiggling around, moving the whole time, doesn't like it. So we're gonna get a bad reading, okay? So this is where most of our assessment's actually gonna live. Once again, appearance, work of breathing, and circulation. So for appearance, what are we looking for? Level of consciousness, right? Are they awake? Yes or no? That's a good answer. Or if they're not awake, can they be roused, right? Are they interactive? Are they engaging with mom and dad? Are they engaging with their environment? What's their muscle tone look like? Are they reaching out actively? Do they look like they can start bending their arms and legs and start engaging, or are they just kind of hanging there limp, okay? AVPU will be modified, right? We're still gonna go down alert, verbal, painful, unresponsive. Now, obviously with kids, they're not gonna understand the words, so just kind of talking to them generally might stimulate some sort of response. And then as far as pain goes, just remember they're small, so we don't wanna leave bruises and things like that. For normal level of consciousness, they're gonna act appropriately for their age, exhibit good muscle tones, once again, their ability to move around, and they're gonna maintain eye contact. Kids have staring problems. I don't know if anyone's ever been around a baby, or maybe recently, whatever, but they just stare, right? They stare around and look at you all the time. So if they're kind of scared to make eye contact or their eyes are not really open, that should be a red flag. You start raising that. Then we can also run down the tickles mnemonic, right? So it's just a good way to remember appearance. What's their muscle tone look like? Are they interactive? Can they be consoled? Can mom or dad get them to stop screaming, crying? Are they looking around? Are they staring? If not, we gotta look into that. Depending on the age, speech or cry, right? How's that cry sound? Is it a strong cry? Is it a weak cry? Right? Because end of the day, a crying baby is a breathing baby, right? But if their cry is weak, that might be a red flag that they're not breathing very well, okay? For work of breathing, increases as the body attempts to compensate for abnormalities in oxygenation and ventilation. This is where we'll start to see that accessory muscle usage, right? The muscles in their sternocleidomastoid, the big muscle in the front of their neck, or maybe even their rib cage, we'll start to see that kind of the skin sucking in around it. Did Kylie show you guys a video of accessory muscle usage at all? Okay, it looks similar. If just think back to that video. If you're having a hard time remembering, YouTube search accessory muscle usage breathing, they will have lots of examples. Now, other things we might notice that can be signs for good or bad breathing. They might have abnormal airway noise, right? Grunting, snoring, squeaking. That accessory muscle use and retractions, those kind of go together. You might see head bobbing, right? They're pulling every time they take a breath. They're trying to open that airway. Same with nasal flaring. They're trying to increase the amount of air they can bring in at one time. Tachypnea, obviously breathing fast, is going to be a sign. Now, how easy do you think tachypnea is going to be to notice in an infant? Does anyone remember how many breaths a minute they can take? 20 to 60, right? So faster than 60, that's going to be hard to count. That's where you got to take your full minute and make sure you're not missing it. Okay, and then the tripod position, right? So hands on knees, bent over, keeping that airway open, right? Those are all signs that things are not looking good and we need to at least assess the breathing further. For circulation, when cardiac output fails, the body shunts blood from areas of lesser need to areas of greater need. We talked about it, their skin, right? We'll start to see pale skin. We'll see that modeling of the skin. Their mucous membranes, may be a little dry, right? Or the color will be off, dry. The color will be off, right? Kind of a pale color. One place that you can check, and it's actually a good place to look for anemia in people, is if you pull their eyelid down and you look inside that lower lid. Is it a pink color or is it a pale color? If it's a pale color, it's probably a hypoperfusion, right? Circulation's poor. Modeling once again, and then cyanosis reflects decreased levels of oxygen. Typically in kids, we'll see it around their mouth, okay? Sometimes we'll see it in their hands and feet. But circumoral, around the mouth, cyanosis is a pretty common and prominent sign that we need to start breathing for this kid. So ABC, or excuse me, the assessment PAT, assessment triangle, right? Keep that in mind. This is something that kind of divvies or changes up rather compared to adults, where we'll just run down our ABCs. We have to go through the PAT. Now, from the PAT findings, you'll decide if the patient's stable or unstable, right? If unstable, then we can move into XABC, right? So PAT, something's wrong. Let's dive into the ABCs. What's going on? Someone tell me what the X stands for.
Exsanguination.
Exsanguination. What does that mean?
Excessive bleeding.
What was it?
Excessive bleeding.
Excessive bleeding, yeah, bleeding all your blood, right? That's kind of the blunt description of it. Yeah, bleeding in excess. So if stable, we're gonna continue with the assessment process. Now, most of these calls, in my experience, not everyone's got the same experience with kiddos. In my experience, most of these calls tend to go pretty well. Okay, I can tell you truthfully, I've had more refusals on kids than I've had transports. Not to say that there haven't been kids I thought should be transported with us. Mom and dad decided to take them themselves. But for the most part, these tend to go, a lot of times people can overreact. A lot of parents will overreact, especially brand new babies, first kid. It's nerve-wracking stuff, I can tell you for sure, okay? Still, bring the calm to the storm, be thorough, PAT, ABCs, let's not miss anything. Yeah, not going to talk about ABCs there because I think at this point we are already fairly aware of what we need to be looking for, okay? I will say with this one, with breathing, right? If we're just observing chest rise or abdominal rise 60 times a minute, that's going to be hard to track, right? Just with your eyes. Rest your hand on them. Obviously not hard enough where we're putting pressure down, but we can rest our hand on their chest, on their stomach. And as that moves, we can count the movement of our own hand rather than trying to eyeball a chest moving 60 times a minute. Okay, it's gonna be a tougher tell. Okay. I do want to talk about, come on. So with kids, hold on, sorry, I went way too far. Okay, for transporting, right? So determine whether we need to do a rapid transport or if we have time to stay and play, right? Turn and burn, stay and play. So reasons to rapidly transport. Trauma, the mechanism, significant. Remember, kids don't handle trauma as well as adults. If there's history compatible with serious illness, if a kid has a history of something like cystic fibrosis, their lungs fill with fluid, that's already a problem for us at baseline. We're gonna have a harder time oxygenating these kids. If we know physical abnormality that's not normal to the patient, right? That's where, once again, ask mom and dad, is this normal for their leg to be like this, arm to be like that? Maybe if it's not, they might look at you like you're an idiot, but just keep that in mind, we're being thorough. Anatomic abnormalities, significant pain, abnormal level of consciousness, all of these are reasons for us to transport quicker, okay? Now, other considerations. Is this a clinical problem? Is this something that they need to have treatment done at a hospital or higher facility of care? Is this something we need to get ALS involved with? Do they have things in their scope that can help out, right? Your protocol will guide you. Comfort levels with kids differ. This is something that if you have children, it tends to actually help a little bit. It hurts you in different regards, but I'll talk about that here in a moment. But for the most part, people who have experience with children kind of know what they're looking for. They know what normal looks like, right? So when they see abnormal, they're quicker to recognize it. I didn't have a child till recently, so when I was actively in the field, a lot of this was learning by experience, unfortunately, which sounds like the majority of you guys are gonna have something similar, right? Pay attention, be a sponge, soak up all the information you can because not every kid's gonna be the same, but a lot of their presentations can be similar, okay? Now, if it's an urgent condition, we just gotta get going, right? Identify, let's move fast. Now, certain things, obviously like MIs, not as likely, not impossible, but not as likely. PEs and strokes, potential, just never know. Okay, so for transporting, we don't wanna just have mom holding the kid or dad holding the kid strapped in the back of the ambulance. Too many risks, too much liability, okay? If it's somebody or kid who's less than 40 pounds, you're gonna transport in their car seat. You can strap a car seat to the gurney. That does work that way, okay? You can mount it straight to the stretcher. And then follow manufacturer's instructions, okay? If you're gonna use the captain's chair, usually we'll just put them on the gurney because think about the space you need to work, right? We wanna get around that kid. And the patients who require spinal immobilization, we're gonna immobilize on a long backboard. Nothing really changes there. There are other devices for kids who are older, or excuse me, heavier than 40 pounds. We still don't want them directly on the gurney, just with the straps, right? If you think about like a 6-year-old, they should still be in a booster seat in a car normally, right? There's one piece of equipment that we carried at my agency that was called the Pediatric. It was basically like a red kind of vinyl thing. It rolled up. You would unroll it, it would strap to your gurney, and then it would have the same buckles as for kids. So it would have the chest piece and then the triangle piece at the bottom that you put them into. There's different options, okay? So whatever agency you guys land at, just make sure you're familiar with what your children or pediatric transport equipment looks like, okay? Especially be familiar. The last thing that you want is somebody, when you have a critical kid, of like, hey, get this on there. And they're like, ooh, I don't know how. Time is of the essence, right? Especially as kids, they need a lot of perfusion. So if we waste time, we're actually, kind of playing with that kid's life a little bit more than we should. Patients in cardiac arrest, right? Use a device that can be secured to the stretcher. For the most part, when I've seen these, we've worked them on seam for the majority. We've also just transported and strapped them down as best we could so that we could function, right? As long as we can do our job. Now it says don't use the pediatric patient's own car seat. For CPR, definitely not. When it comes to transporting a kid under 40 pounds, we don't carry car seats. So you're probably gonna take mom and dad's car seat with you. And remember, the goal is to secure and protect the pediatric patient for the transport in the ambulance. Ambulances get in wrecks all the time. They're not an invincible vehicle. I myself have been in an ambulance wreck. It happens. People don't pay attention. It's not always us we're looking out for, okay? Other people make the mistakes, so keep that in mind. Even if the person driving your ambulance is doing a great job, someone can still hit them, okay? It's kind of the risk we run messing with, traffic laws. Okay, history depends on the patient, right? So I'll have you guys flick through that one on your own time. Secondary, the big one, remember foot to head until they hit about that school age, depending on the age, right? Then we can start a head to toe. That's gonna be the big one. Decap BTLS, if we're talking little kids looking at the head, we gotta be aware of the fontanelles. Remember, if it's sunk, that's a good sign of dehydration, maybe hypovolemia. If it's bulging, inversely, we could have ICP or intracranial pressure showing up. Nose, remember infants are nose breathers for the most part. Okay, so they could have congestion, just try to get that cleared. Okay, suction that out. You'll be using, for the most part, depending on the size of the kid, you can use regular suction if they're big enough. If they're not, I'm sure we've all seen those bulb syringes probably around your house growing up, right? The little bulb and the thing coming out the end. Not crazy, right? People know what I'm talking about. Okay. For ears, same thing, drainage. We're looking for that potential halo sign, battle signs, raccoon eyes, pus. Pus may indicate infection. Here's a pro tip for you. When you're going to be writing charts, which you're going to be writing plenty of charts, if a wound has pus in it, you are not going to use the word pussy to describe it, because when you spell it out, it's not going to say what you think it's going to say. And that's all. I'll leave that kind of there. Just keep that in mind. Be tactful with your words. For mouth, bleeding, loose teeth, remember kids start losing their teeth. Teeth are airway obstructors, especially when their throat is the diameter of a straw, okay? And then note the smell of breath. Depending on the age, could dictate a few different things. Just keep that in mind. If we're, smell like that, like kind of metallic penny type smell, like blood, right? Things that we could be aware of, or even vomit. I can tell you a lot of kids, I can tell if they've had a good breakfast or not, just based on the smell of their mouth and what I see on their shirt. For the neck, trachea, right? Swelling or bruising. Nothing's really changing. Decap BTLS. If they cannot move their neck and have a high fever, though, we have to make note of that. Why? What potential illness are we talking about? Stiff neck, high fever, probably a headache too. Was it? Meningitis, yeah. Meningitis, remember, meningitis is contagious and you do not want meningitis, okay? Chest, penetrating trauma, lax, bruises, rashes. Feel the clavicles, right? And every rib, be thorough, don't miss things, okay? Be keen on deformities. Some kids will have like rib malformation, so just ask, is that a normal rib for them or not? Back decap BTLS, sheesh. Decap BTLS still continuing. Abdomen, we're thinking about distension, but if we see distension in the abdomen, what else do we need to pay attention to for kids? If there's swelling and bloating in their stomach, what are they not doing as well? Breathing, right? They're not breathing as well, so make sure that we're considering that as a factor. Gently palpate, watch for guarding or tensing of muscles, note tenderness or masses, seatbelt marks, right? Either bruising or abrasions could be potential, especially if we're talking kids who are too young to be riding in a seat unrestrained. You're gonna see over the soft tissues, you'll see the seatbelt marks, okay, maybe even higher up on the neck if they have that chest strap down. For extremities, assess for symmetry. Remember, we're gonna still be doing our CMS, PMS, circulation, motor function, sensory function. Okay, compare both sides, color, warmth, size of joints, swelling, tenderness. Put each joint through full range while watching the patient's eyes. Remember, kids can't tell us, okay? But kids will let you know if they're in pain. They're either gonna scream, or if you watch their eyes, you're gonna see a reaction, okay? Usually tearing. Okay, vital signs, like I was saying, I already kind of did my spiel on those, okay? Have a table available, make sure you have something easily accessible to you. And then once again, under the age of 3, we don't typically get a blood pressure, okay? And that's just because of other factors to getting an accurate number. Usually what we'll do for kids under 3 is we'll just do 70 plus 2 times their age, okay? So if they're 4, it'd be 78 systolic, okay? That's usually what we'll go off of. But if you're going through the PAT and you can see that the skin is flushed, you can probably assume that blood pressure is fine. Okay. Appropriately sized equipment, you will have pediatric sized stuff, OPAs, MPAs, intubation sets, IVs, medication doses, all the things. I'll tell you kind of our cheat sheet that we use out there, okay? Here's that formula if you're curious about that. Systolic blood pressure, 70 plus 2 times their age, usually 1 to 10 is when we'll get that. After 10, kids for the most part will let you get a blood pressure, okay? Yep, get your respirations. If we're having a hard time counting them, 30 seconds might not be enough. Count the full minute if you have to, okay? And then remember, it's not just chest rise, we'll look for abdominal rise as well in kiddos, because kids can be belly breathers. Okay, yeah, pulse, same thing as the breathing. If they're ticking along at 205 beats per minute, you might have to count for the full minute, okay? Be thorough. Vitals change, pupils will be the same, right? We're still going to assess the same way. And then pulse ox, that's gonna be a good one. Is the pulse ox always reliable? No, right? There's a lot of factors like nail polish, dirt, cold, too much light. Those will all throw the SpO2 off. On top of it, if we're talking about a 4-year-old, you think they're gonna keep that thing on their finger? No. So with kids, we actually have SpO2s that are stickers, and you'll stick them on the fingers. Pro tip, put it on their toes. They're less likely to fiddle with it and pick it off that way. But I've even put them on their like ears before. If I couldn't get their fingers and toes were wiggling or I'm getting poor readings, put it on the ear. That one will also work, okay? Questions at all? Okay. Reassess 5:15 as needed. Keep parents in the loop. Okay. So now we're gonna kind of shift gears. We're gonna start talking about conditions. Now, some of these conditions we've already talked about. Croup, epiglottitis should be fairly familiar at this point, okay? So I'm gonna ask everybody as we progress, how do we feel about this? If we're not feeling great, we will move on, or we'll stop. If we're feeling good about it, I'm gonna move past it, okay, just for time saving. So respiratory problems, leading cause of cardiac arrest in the pediatric population. Remember with adults, it tends to be an inverse relationship. Adults, their heart fails, and as their heart fails, their respiratory values drop. Kids are different. Kids are opposite. Kids are breathers inherently. They need more oxygen. So when it comes to a kid going into cardiac arrest, their respiratory rate and volume will drop, and then along with it goes the cardiac function, okay? Oxygen tends to be one of the best treatments for kids, just generally. In fact, even at the paramedic scope, if we have a kid who's, say, bradycardic at a rate of 40 or whatever that number looks like, the treatment is oxygen. And you'll see that heart rate start to climb as you're meeting perfusion needs, okay, cellular demand. So in the early stages, you may note changes in behavior such as combativeness, restlessness, and anxiety, right? So kids are gonna be pushing away with their hands, gonna be trying to figure out what's going on. That's for us to step in and tell them, or at least find it. So some signs and symptoms we might see: that nasal flaring, they're making their nostrils nice and wide, getting as much air as they can. All of the breath sounds are still on the table: stridor, wheezing, bronchi, crackles, rails, all on the table. And then accessory muscle usage, pretty common in kids, because remember, kids will compensate very well until they do not. And then that tripod positioning, depending on the age, okay? You might even notice them throwing their head up to try and line up that airway. So as the pediatric patient progresses to possible respiratory failure, we have reached the point they are no longer in distress. They are working their way down the tubes. They're gonna start to see that effort to breathe decrease. Okay, remember, and it could be sudden, depending on the severity. So the chest rise is gonna be a lot more minimal, or the abdominal rise will be minimal. Okay, they're not gonna take the extra steps to breathe. And the body at that point has used up all available energy stores and cannot continue to support extra work of breathing. Okay, remember, once again, their perfusion needs are very, very high because their body's changing and growing. So to match that cellular demand of growth, they need a lot of oxygen and a lot of sugar. Okay, well, if they're working really hard, they're burning through that sugar very, very quickly. Okay, so they come to a point their body physically cannot keep up with the demand. Continuing, so changes in behavior eventually alter level of consciousness. They will eventually go unresponsive. Okay, kind of tracks with most people who stop breathing well. Patient may experience periods of apnea, so they'll kind of do that Cheyne-Stokes breathing where they'll go through that kind of silent, minimal breathing. Might have a couple flutter breaths here and there, but they'll go through those kind of periods. Once again, this is where we use our BVM, positive pressure ventilation, and we'll start to see that change. The heart muscle becomes hypoxic, right? And with lack of fuel, the engine slows down. So you'll start to see that heart rate dropping, getting lower and lower and lower as the oxygen levels get lower. Now, respiratory failure does not always mean they have an airway obstruction, which, side note, what is the sound we would likely hear if we have an obstruction of the airway? Stridor, yeah, stridor, our only upper airway sound, right? We'll hear that kind of sing-songy whistling sound, okay? Now, the condition can progress from respiratory distress to failure at any time. Remember, kids decompensate quickly. I know I'm beating that horse over the head, but that was a blending of a lot of things, but keep that in mind. They are gonna definitely need supplemental oxygen. Kids are breathers. If we are not matching their cellular demand with oxygen, things are gonna start going downhill. Okay, so remember, if they're conscious, we can use our BVM, and you're gonna basically assist their breaths. As they take a breath, you're just gonna give them a small puff of air using your pediatric BVM, so we're not overinflating, right? But we're gonna continue that until we can get a normal rate going with our bag, okay? And then allow the patient to remain comfortable. And I would kind of caveat that as comfortable as possible, okay? Don't let them get comfortable like, oh, I only like laying on my stomach. Well, we can't manage an airway that way, okay? As comfortable as we can make them. Questions on this at all? Okay. For airway obstruction, so children can obstruct their airway with any object that can fit in their mouth. And as we've kind of talked about earlier, kids put things in their mouth. That's their sensory feedback from their environment. Okay, so in cases of trauma, you might have teeth dislodged in the airway. But yeah, all sorts of candy, coins, buttons, toys. Fun fact about lifesavers. The reason there's a hole in the middle is because the founder, the creator of lifesavers, I don't know if it was his kid or he heard about somebody else's child, but they passed away choking on a hard candy. So he put a hole in the middle so they could still breathe. Fun facts. But yeah, anything. A lot of the chokings that I've seen with kids has actually been coins, more frequently than not. One in particular showed up, it was like a 3-year-old choking. So already, everyone's up here. And then when we get there, kid was breathing, kid had swallowed it. So then I was talking to mom, she's like, I just don't know how he could have got a hold of that coin. And I looked at her apartment and it was just coins, like as far as you could see. It's like, could be anything, right? So sometimes you're gonna have to really, I don't wanna say call the parent out, but make them aware of the environment, right? Well, there's coins everywhere. So that might be something worth picking up. I don't know. Okay, so blood, vomit, secretions, we already know small airways, so anything extra that's not supposed to be there runs the risk of aspiration, Aspiration is breathing things, not air. So if you puke in your mouth and breathe in all your vomit, that's aspiration, right? Same thing with kids. Infections can cause obstruction. Remember, not always going to be things like choking necessarily. Could be things like fever or epiglottitis or croup, right? We start to see the swelling of the airway there. But infection should be considered if the patient has congestion, fever, drooling, and cold symptoms. Okay, now croup is an infection of the airway below the vocal cords, right? So it'll be more of a lower airway issue. Epiglottitis is going to be upper epiglottis, right? The flap that covers our airway when we swallow, okay? Inflammation there. Croup, I want to make this a note. I would remember this. Croup is a viral condition, a viral infection. Epiglottitis is a bacterial infection. Now, even if obviously we don't have the labs, we can't do blood work. How can we tell if an infection is likely viral or bacterial? Someone tell me. Based on something we can feel. Anybody? What is something that happens to us when we get sick most commonly? If you feel somebody when they're sick, what are you likely feeling for?
Fever.
A fever. Yeah, so we can tell the difference between viral and bacterial based on the fever temperature. Virals tend to be more of your 100 to 101 type temps. Bacterials are usually higher, 101 to 103. Okay, now, is that going to be surefire every time? Can't guarantee every time, but for the most part, that still rings true. There's still going to be factors, right? Were they under a bunch of blankets? Were they wearing jackets under the blankets, right? That's going to alter their temperature kind of abnormally. But keep that in mind. The different temperatures can tell us what's going on. Croup is viral, epiglottitis is bacterial. So this is a picture of epiglottitis. You can see this epiglottis is pretty big. Now we already know kids' epiglottis is a little bit different than adults. It's bigger, it's floppier, it's different shape, right? When I was in medic school, my instructor basically told us, do nothing to mess with that airway. Because if that falls down and it blocks that airway, it's going to be a heck of a time to try and get that back up. Even with an intubation blade and forceps in there, it's almost impossible to get it off. These kids, if that falls down, we end up doing needle cracks, and we'll put a needle through their throat and breathe through that. Okay, so keep that in mind. So obstruction by foreign object may involve upper or lower airway. Okay, depends on how far it went. Can be partial or complete. So remember, if it's a partial obstruction and they can still move air, they can still breathe, we're not going to get overly involved. Reason being is we want to see if they can clear that themselves. Also, by us meddling, we could make it worse. Okay? If it's complete, we got to get involved. If we have a choking of a child, let's say 6 years old, what should we do? What do we do to get rid of choking for a 6-year-old? Is it anything different than an adult? Sorry if someone's talking. No. So what do? Heimlich maneuver, abdominal thrusts, right? Yeah, abdominal thrusts. Let's say we're doing the abdominal thrust and that kid goes unconscious and we don't clear it. What do? CPR, right? We move to doing chest compressions at that point. Yeah, now if it's like a baby infant, we're gonna do the 5 back slaps, flip over, 5 chest compressions, back and forth it. Okay? Now signs and symptoms of an airway obstruction can be, so partial upper obstruction, we'll see decreased breath sounds and stridor, right? 'Cause something's blocking that upper airway. If it's lower obstruction, we're gonna hear wheezing or crackles, right? Wheezing is just another fancy way of saying bronchospasm. Okay, so the bronchi are tightening up. So you might hear that down lower. Already kind of talked about it with kids. Most of their anatomy is anterior. So when it comes to listening to breath sounds, listen to the front, okay? And then make sure it's armpit level because remember they have smaller lungs, so they're all up higher in the chest, okay? Excuse me. Immediately begin treatment of airway obstruction. So if we have a partial, encourage coughing when the patient's conscious. We want them to cough. We want them to try and clear it themselves. If this does not remove the object, do not intervene except to provide oxygen. And we'll talk about different methods down the road here. Allow patients to remain in whatever position is most comfortable. Usually with breathers, how do we want to position them? Do we want them lying flat on their back? No, how do we want to position them? Seated. right? If we can get them sat up, use gravity to your advantage. If I'm laying on my back, gravity's pulling my whole lung down, right? If I'm sitting up, gravity is working in my favor to help my lungs expand, my diaphragm pull. Okay, so use that to your advantage. If we see signs of severe airway obstruction, right, we got to start clearing it. So we already talked about it. We're going to do abdominal thrusts, right? We might move into chest compressions depending on consciousness. But if they have an ineffective cough, no sound, they're just going through the motion. If they have the inability to speak or cry, but they're making the faces like they're trying, that should be a sign, right? If we see increasing respiratory difficulty with stridor, okay, that upper airway sound, once again, coming back, right? We got to get involved. Cyanosis, what does cyanosis usually mean? Is what?
Blue color in the mouth.
Blue color in the mouth, what's that indicates going on? Low oxygen, hypoxia, very good. And then loss of consciousness will follow. So if an infant is conscious with complete airway obstruction, perform the 5 back blows, flip them over, chest compressions. Okay, if they're conscious, we're going to do the Heimlich maneuver until they lose consciousness, and then we're going to move into chest compressions. Head tilt, chin lift, nothing really changes there. Do we blind finger sweep ever? No, why? What could we end up doing? Get it worse, yeah. We're going to end up pushing that in there on accident. So if we see that, you can flick it out, okay? Head tilt, chin lift, finger sweep to remove visible foreign body in an unconscious pediatric patient. And then chest compressions to relieve severe airway obstruction if they're unconscious, right? We can't do abdominal thrusts if they are unconscious, right? Because we want to make sure that airway stays open. So if it pops out, it pops out. Okay, questions at all so far? Okay, now we're going to get into these conditions. So asthma, condition in which bronchioles become inflamed, swell, produce excessive mucus, leading to difficulty breathing. What is the sound we're going to hear with asthma? Wheezing, right? That sing-songy sound in their chest, yeah. Now, has anyone ever had an asthma attack in here before? It's okay if you don't want to disclose. Okay, well, I had asthma as a kid, and I can tell you they suck. That air hunger and not being able to catch your breath is really, really hard, okay? Especially with kids, we know that if they don't breathe well, they tend to decompensate quickly, okay? So we need to recognize fast. This is where history will solve our mystery, but we can also, well, what's our treatment for asthma? Albuterol, right? We can maybe get a neb going, yeah. It's true emergency if not promptly identified and treated, and then common causes include upper respiratory infections, exercise, exposure to cold or smoke, and then emotional stress. All of those are potential indicators or potential causes of asthma attacks, and it really depends person to person. I was more exercise-induced. I know people who have gone into asthma attacks because of anxiety. I know smoke can really mess, like when we get those fires here in the valley, I know that smoke really messes with people too. So remember, signs, symptoms of asthma: wheezing, right? Usually expiratory, wheezing as an expiratory sound. They can get the air in, it gets trapped, so as they try to breathe through it, that tight window there where they can't get the air back out. Okay, now in some cases, airway is completely blocked with no air movement heard. Once again, get a neb going as best you can. Cyanosis and respiratory arrest will quickly develop. Okay, remember that kids are breathers, once again, and if we fail to recognize this, they are likely to go into respiratory arrest, which leads to cardiac arrest because kids, once again, are breathers. And then you'll see this tripoding position. It helps them to just open the airway up. Okay, they're kind of manually opening, keeping that a straight line. So get them as comfortable as possible, get them oxygen. Our bronchodilator of choice is albuterol for the most part, depending on your agency. And then if you're assisting ventilations, remember, we don't want to get too amped up. We don't want to overinflate because we can pop lungs in kids if we're not careful, okay? And then contact ALS. This is definitely one where if you're having a hard time controlling it, ALS can intervene and start getting some more things moving. Questions on asthma? Okay. Pneumonia, leading cause of death in children. Okay. Pneumonia just generally is a bit of an umbrella term for just lung infection. Usually pneumonia is a secondary to some sort of prior infection. Okay. General term refers to infection of the lungs, often secondary, can occur from chemical ingestion, right? So just depending on what they breathed in. There can be diseases that have an increased risk, I already talked about it, but like cystic fibrosis, they have fluid in their lungs. They already are predisposed to infection in their lungs, okay? And then incidents are greatest during fall and winter months, kind of cold and flu season, which makes sense. It's cold, everyone kind of packs in, and as we know, schools with kids, right, they pack everybody in there. They go outside, but it's still limited. And if one person gets sick in a tight room, everyone gets sick in that tight room eventually. Okay, so it just kind of adds up as to why it would follow up a secondary illness there. So for our pediatric assessment triangle, right, rapid breathing, work of breathing. If they're breathing really, really fast, that's a sign that we need to get involved. Or if we hear grunting, wheezing, snoring sounds, got to get involved. If we see that nasal flaring, tachypnea, okay, hypothermia, or fever, really just depends on the kid, depends on how progressed it is, okay? And if we have unilateral diminished breath sounds or crackles over the infected lung segments. Has anyone ever seen an X-ray of pneumonia before? Let's pull one of those up so you can see why you're going to hear diminished sounds. You can see why you're hearing the bronchitis, that infection. Pneumonia, chest X-ray. Yeah. So if we look at this image here, the right lung, because remember it's patient's right lung is clear for the most part, maybe a little segment. The left lung, does everyone see that cloudiness there? That's infection. That's all that mucus infection kind of breeding in that area. Okay, so that's why you're hearing that rhonchi in here. You're hearing that mucus move around. Okay, questions on this at all? And it really can depend. You can have them all over. You can even have like spottier ones. Oh, this is COVID. Oh, and pneumonia. But you can actually see where this is following the bronchi and the bronchioles in this X-ray. Okay, so this is what you're hearing and why you hear that. So if you have a diminished sound, it's because they're not moving air because there's so much gook in that lung that it physically can't get past it. Okay. Okay, so for our treatments of pneumonia, it's going to be mostly supportive. So ABC management, okay, get them oxygen, assist respirations as needed, okay, but for sure monitoring the airway and breathing. Supplemental oxygen, like I talked about. If they're wheezing, right, we can give a bronchodilator. With pneumonia, I've seen it a few times too, where if you listen and they have a really quiet chest, or maybe you hear a little wheezing, if you give them albuterol, it's going to open them up to the extent you're going to hear it a lot better. Okay, because now you can actually hear the stuff moving around in there. It's not so tight, it's not grabbing onto the walls of everything. And lastly, we do not diagnose pneumonia. They need chest x-rays, they need labs drawn. Nothing we can do. We can have strong suspicions of, but we can't confirm that with our limited availability of tech. Questions on pneumonia? Okay. Moving to Croup. How's everyone feel about Croup? Feel okay? Someone feel not good about this? Oh, you guys are real talkative, I forget. Okay, well, I'm just gonna go through it then. Croup, lower airway, already talked about it. So an infection of the airway below the level of the vocal cords, usually caused by a virus. Now, most commonly seen in kids between 6 months and 3 years, and this is very contagious. Kid to kid, this will hop around. Okay, starts with a cold, we'll move to a cough with a low-grade fever developing over 2 days or so, with the hallmark sign being stridor and a seal bark cough. Let's pull that up because I want you to hear it. Seal bark. Let's see if I can get, let's see if this is, oh, cool, no sound, that helps. Let's try this again.
That's how it comes out? I think that's...
What? Can I hear that?
I think that's a normal.
Let's see, there's a better one. I think it's this one.
So you want to play guitar? What do you think to yourself?
I don't really want to, but... Okay. Yeah.
Let's have a listen to a few children who actually have Croup to hear what the sounds are like.
You hear that? That seal barking sound? And it's kind of that higher pitch. So you'll hear it. Once you hear it, you almost know instantly. Now, it's one of those things too, if the kid's coughing around it, you'll hear a couple normal coughs and then maybe you'll get that seal bark with it. Or depending on the severity, they may straight up just start seal bark coughing from the get-go, okay? Okay, so treatment usually responds well to humidified oxygen. Easy way to do that, put a little bit of saline in a nebulizer. Get that nebulizer rolling, that's humidified air. It's the same concept as when you're sick and you have maybe a chest cold, you go stand in a hot shower and that steam starts to break up and you start coughing, start breaking up all the stuff in your lungs. Same idea. Bronchodilators are not indicated for croup, just because it allows, basically with that expansion, it'll allow that, basically give that infection more room to grow. So we try to bypass it. Another one, and this is really situational time of year that is not often talked about, is if it's cold outside, take them outside, okay? That cold air will actually act almost like an ice pack for the inside of their lungs. And so it'll just bring some of that inflammation down. So have them breathe some cold air. Now, obviously, that's pretty dependent on where you live, dependent on time of year. So humidified oxygen is gonna be our go-to, okay? Questions on croup? Okay. Epiglottitis, talked about it already. Bacterial infection, soft tissue of the area above the vocal cords, more specifically the epiglottis. Itis inflammation, epiglottis, inflammation of the epiglottis. Okay, so incidence of decreased since development of a vaccine. Okay, so this is one that we will vaccinate against. Can swell 2 to 3 times their normal size, and I'm gonna say it again, be really careful with these kids' airways. We don't want them getting upset, we don't want them screaming, okay, because that can all cause that epiglottis to start being affected. Now the child will look ill, report a sore throat, and will have a very high fever, okay? The higher the fever, indication for bacteria, okay? And the calling card of this one is drooling. These kids will drool excessively. Like think about like a dog with a treat in front of it. They will drool to that extent, okay? Questions on epiglottitis? Okay. Bronchiolitis, kind of following the train, right? So specific viral illness in newborns and toddlers, usually followed by RSV, respiratory syncytial virus, okay, which is another common kid disorder, common kid illness. Causes inflammation of the bronchioles. So remember, our bronchi will branch out smaller and smaller. Those are the bronchioles, okay? Now RSV itself, highly contagious, can spread through coughing and sneezing. RSV is one that adults can also get pretty bad. My wife got a nasty case of RSV a few years back from the homeless shelter because one person in the homeless shelter had RSV, which means everybody's getting RSV when they're all packing in there, okay? And because it's a virus, it can also survive on surfaces. So this is one that we will disinfect surfaces after we have this patient. And the virus tends to spread rapidly through schools and in child care centers because once again, if you're putting a bunch of sick kids in one room, not everyone's gonna walk out of that unscathed, okay? Very common though in premature infants, results in copious secretions. They have a lot of fluids coming out, a lot of saliva, drooling, maybe even mucus. Occurs during the first 2 years of life, with it being more common in males. Not entirely sure as to why just males there, but most widespread in winter and early spring. The bronchioles will become inflamed, swell, fill with mucus. And then with that swelling and mucus filling and a tighter tube, they have a higher likelihood of that airway becoming blocked, okay? So for us, signs we're gonna see dehydration, maybe shortness of breath and fever, okay? Don't be surprised if you can't catch this one. It's just, because if we think about it, right? If you put someone who has the cold next to someone who has COVID, they're probably gonna look fairly similar from just the top down, okay? So don't be surprised if you're like, I can't figure out exactly what they have. It's not for us to decide, right? That's why they have doctors and labs and all the fun stuff. Now for our treatment of bronchiolitis, calm demeanor when approaching. Remember, bring the calm to the storm. The better relaxed they are, the easier it'll be. Allow the patient to remain in a position of comfort. Treat airway and breathing problems as needed, right? So we can give oxygen, positive pressure ventilations. Humidified air will also help. Anytime we have that big buildup of mucus in the chest and you hear rhonchi or you have diminished sounds, that's where humidified oxygen can start helping. And then ALS backup as well can go a long way. Okay, pertussis. What's another name for pertussis? Whooping cough. There we go, yeah. So, caused by bacterium spread via respiratory droplets. It spreads from the cough. Not super common in the US. This is one that we vaccinate very early for. It's part of the Tdap vaccination, tetanus, diphtheria, and pertussis. Okay, now signs and symptoms, coughing, sneezing, runny nose. They will have that coughing that gets so extreme, they cough, 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 and then they go, right? And it's like kind of the wave sound, right? The whooping sound there. Now, infants may also, if it goes untreated, can progress once again into things like pneumonia, okay? And then if not treated even further, respiratory distress. If respiratory distress is not caught, respiratory failure, and cardiac arrest, and so on and so forth, okay? Now for treatments, keep that airway open. Transport, also remember this is a very contagious one. Wear your mask, wear your goggles, wear your PPE. Okay, you don't want to get coughed in the eye by pertussis because you could still catch it that way. Okay, questions? Okay. Okay, we already kind of talked about adjuncts, but let's talk some more. So devices to help maintain the airway or assist in providing artificial ventilation. So OPAs, MPAs, they're great. Bite blocks, yeah, we carry little rubber stoppers that we'll actually put in their mouth to hold the mouth open if we have to. And then your BVM. Your BVM will be specific to kids. Now, I already kind of touched on this, but they have a larger tongue. This is a question that an EMT loves to throw around. They have a larger tongue, so when it comes to inserting an OPA, we have to tongue depress and then follow the shape. We place it concave. There's no rotating. You're not just going to blindly put it in there because you could catch the tongue and end up pushing it back, okay? Now, it should be used for pediatric patients who are unconscious and in respiratory failure, and should not be used in conscious patients because gag reflex, right? If we put something in their mouth, they have a gag reflex, there's vomit, and then our airway's already gotten worse, okay? And then if they've ingested anything caustic or petroleum-based, that could also do some damage. What does caustic mean? Can someone tell me?
Acidic? I mean, it's like...
Kind of like, acidic's a good way to phrase it. Yeah, like an acid, it eats away at stuff, right? So if you get it like something caustic, like if you inhaled some sort of like acidic agent, that could start eating away the tissues inside of you, right? Same idea. For MPAs, usually these go a long way, okay? Remember, usually in my care, I'd start with an OPA. If the OPA doesn't work, then we'd move to MPAs. But well tolerated, used for responsive pediatric patients. We'll use it also if there's possible respiratory failure. Now, realistically, kids younger than 1 year old, we don't use them for, and that's mostly sizing, okay? And OPAs are gonna be your way to go with those. And then should not be used if there's a nasal obstruction or head trauma. The contraindications are still there. Also remember, nasal obstruction, kids start putting things up their nose, okay? My sister liked to put peas up her nose growing up. So keep that in mind, you're not gonna have access to something that's got a door blocking it. So potential problems. It can become obstructed by mucus, blood, vomits, or if the soft tissues are swelling up, right? Another thing, remember our vagus nerve, cranial nerve 10. It actually reaches all the way down to our heart. So if you have them bearing down, they're like expecting it, or if you're blocking that air for too long, it can actually bring the heart rate down, okay? It can also, because the airway and anatomy is so tight, you can end up putting it into the esophagus. Okay, this is why it's a little bit rougher. Now, it may cause spasm of the larynx, result in vomiting if inserted into a responsive patient. Has anyone ever had an MPA put in before? Good, you want to keep it that way. I had one put in when I was in medic school just to see what it felt like, and the answer is awful. I was gagging the whole time because it does reach all the way down, basically at the level of your tongue. Okay, and then should not be used when pediatric patients have facial trauma, because once again, we could end up inserting it into their brain, just like with adults. Okay, and then they have that finer finer soft tissue. So we could actually end up damaging soft tissue if we're being too aggressive with that. Okay, I'm gonna get through this and we'll take another break. Okay, so hold on. And for the most part, I'm actually gonna skip through non-rebreathers, BVMs, and nasal cannulas because those are basically the same, right? Obviously with the pediatric sizing involved. But the one I want to talk about is blow-by oxygen. So blow-by oxygen, less effective than a non-rebreather or a nasal cannula, but let's think about it for a second. Do you think a 3-year-old is going to tolerate a nasal cannula in their nose? No. They try to rip that out every single time. Now, blow-by, if we need good, that's not a good way to phrase it. If we need more oxygen administered, we will try to get a different device on. But typically, if we need a bigger device, the presentation is going to be one that warrants it, right? So less conscious, things like that. But does not provide high flow concentration. So what we'll do, or what we do with this, is in the hospital, they'll take a cup, like a paper cup, punch a hole in it, and they'll put oxygen tubing straight through that hole, and then crank it like to 15 or higher if they have it. And then all you'll do is hold it by their face. And as they breathe, they're passively getting more oxygen. Now, we don't carry paper cups, so what I've done historically is I've just inflated a non-rebreather mask all the way, make sure that bag is all the way inflated, and then just hold it by their face. This is also a good job to give to parents because they want to help. They want to help their kids. So if you can, hey, hold this by their face, I just need them to kind of breathe that ambiently. Most parents are going to try and do the most. They'll even get as close as holding it on their face, which also works for us, right? But place tubing through hole in bottom of cup, connect tube to oxygen. It says at 6, I would crank it at 15, that's just me. And then hold the cup 1 to 2 inches away from their nose and mouth. You can also use blow-by in adults as needed. I know I've been talking about my sister a lot in this lecture, but she ended up having seizures a few years ago. And when I was in the hospital room while she was having one of them, I was instructed by the doctor just to hold blow-by the whole time. Okay, so sometimes you can use it for adults. Questions on blow-by oxygen? Okay, remember this is kind of our minor administration. If we have to, we got to try and get that non-rebreather on their face. Okay. Okay, and then this is the picture right here of blow-by. And then just depending on, if you're taking somebody from like a pediatric clinic, they may have some sort of setup that you can just take with you, okay? All right, and nothing really changes outside of the volumes on our BVM. They're gonna be smaller because kids have smaller lungs. Okay, so just make sure you're not squeezing that really aggressively. We don't wanna pop lungs. It's a slow, gradual climb, making sure we're delivering that oxygen effectively. And then the 2-person technique does actually work really good for kids. Remember the CE for adults or for single person ventilation. With pediatrics, not even pediatrics, with other people, it's generally if you're gonna use 2 hands, I like to do this way. So my thumbs would be on the mask itself and then I'd grab the jaw with my fingers, okay? So thumb down, holding the mask in place, creating a good seal around the mouth, and then pulling the jaw into the mask, and then the other person will be bagging, right? But it works really, really well with kids, especially because they got small faces, so it helps us maintain a better seal, okay? All right, let's take another break. We'll come back in 10 minutes. We'll call it 3:13. Well, let's keep this train rolling. So moving into cardiac arrest. So cardiac arrest in peds, remember, they stop breathing before their heart. Adults, their heart stops working and the breathing follows. So it's a little bit inverse. As long as you can remember, kids need oxygen. That's the big one, okay? So children are affected differently by decreasing oxygen concentration with hypoxia leading towards bradycardia, okay? So our treatment of choice is gonna be oxygen. Now, questions that they love to throw out. If we're talking 1 rescuer, pediatric, what is our ratio of compressions to breaths? Single rescuer. What is it? 30 and 2. 30 and 2. 30 and 2. Now, if we're talking 2 rescuers, what is it? 15 and 2. The way I always think about it is that if we have 2 people, we can get twice as much oxygen, right? Because if we're doing less compressions, we're giving more air. Okay, so single rescuer, 30 and 2. 2 rescuer, 15 and 2. That will come up, I promise you. Okay, now moving into shock. We've already talked kind of about how they compensate very well until they don't. Now, shock develops when the circulatory system is unable to deliver sufficient amount of blood to the organs, right? So hypoperfusion. Now, this is eventually going to result in organ failure, and then as that progresses, cardiac arrest, right? Depending on the type of shock. Now, compensated shock, remember, is earlier. So if we're in compensated shock, my blood pressure is dropping. What's starting to change? If I'm in shock and my blood pressure is dropping, what's changing to try and keep me afloat?
Heart rate?
Our heart rate, yep, our heart rate goes up, right? Very good. Versus inversely, if we're talking decompensated shock, we can no longer maintain and everything starts going downhill, which for kids is more of a stark drop. Now, common causes, injury with blood loss, dehydration from diarrhea and vomiting, hypovolemia goes past bleeding, okay? Remember, even burns can cause people to become hypovolemic. That's why when you touch somewhere you've burned, it feels slimy and sticky. That's plasma. You can become hypovolemic because of plasma loss. Okay, severe infection, if we're talking sepsis, neurologic injury, maybe neurogenic shock, we can start putting pieces together. Anaphylaxis, already touched on that. What is our pediatric dose of epinephrine? 0.15 what? Milligrams, very good. Yeah, diseases of the heart, which hopefully we will know from parents if we get a good history, but things like murmurs, right? Valve issues, not uncommon. We could have a tension pneumothorax. Can someone tell me when a pneumothorax progresses to a tension pneumothorax? What happens? Decrease what?
The trach is being deviated, right? It's like being shifted to the one side.
Yeah. So our great vessels are moving, right? That mediastinum or mediastinum, however you want to pronounce it, is shifting, right? That just means that we essentially have air kinking the great vessels, kinking the aorta, kinking the vena cava, okay? So that means we have less blood going out and less blood returning because of the pressure in our chest, okay? So as far as vital signs go, we might see a drop in blood pressure, or rather we would see a drop in blood pressure when we are progressing to a tension pneumothorax versus a normal pneumo, okay? Now if we have blood around the heart, cardiac tamponade, right? So we have the fluid around the heart, between the heart and that pericardial sac. We also have pericarditis, so the pericardial sac itself is swelling up, putting pressure on the heart. Which triad follows cardiac tamponade? Which triad? There's only two. Beck's, correct. Beck's triad, yeah. So we're gonna see that hypotension, muffled heart tones, and JVD, jugular vein distension. Okay, good. So pediatric patients respond differently than adults to fluid loss, right? So they may respond with an increasing heart rate, increasing respirations, right? Because they're trying to get more blood circulating, they're trying to get more oxygen moving, okay? But then we'll also see signs of pale or maybe mottling or blue skin because they're shunting that blood to the important keep alive organs. Now, for signs of shock, tachycardia, which our kids' heart rate's normally pretty fast, right? So they're going to be at a really high rate. Okay, we might have poor cap refill time, mental status changes, so they're going to seem more altered. They're not going to be acting appropriately per mom and dad because we're not going to know that, right? And then so as far as treatment goes, we're still going to do CAB, right, or XABC, manage major bleeding, okay? And then from there, we're going to move into ABC management. Remember also, if they move into cardiac arrest, we're going to be doing CPR, which once again, 30 and 2 for single, 15 and 2 for double rescuer. Now, remember with kids especially, everybody, but in particular kids, blood pressure does not fall until shock is severe. Okay, it's a really late sign. Now, as far as our treatments go, limit your management to simple interventions, right? Lay them position supine, maybe get their feet up to Trendelenburg, cover with a blanket, high flow oxygen, transport, pretty straightforward stuff. If we can do it in the moving ambulance, let's do it in the moving ambulance. We don't want to hang out on scene if we know end of the day we can't do anything. We got to get them to a hospital, okay? Keep that airway open. We'll artificially ventilate as needed, control bleeding, right? So as far as how oxygen is being delivered is kind of dependent on the situation. If they're apneic, BVM. If they have a respiratory drive, we can put a BVM on them, okay? Or even blow by, not BVM, non-rebreather, or blow by. Okay, continue to monitor the airway and breathing, position of comfort, which more often than not, depending on the shock, we need them in some sort of supine, okay? Keep them warm, provide immediate transport, and then once again, ALS. We can get IVs, we can get fluid resuscitation started, we can get pressors, all sorts of things, okay? Now for anaphylaxis, we already talked about it, 0.15 milligrams IM of epinephrine. Remember, there's a difference between an allergic reaction and anaphylaxis, okay? Anaphylaxis is multi-system. So airway, skin, GI, we might start seeing interactions there, okay? Characterized by airway swelling, dilation of blood vessels. Remember, it is a vasodilatory type shock. And then with the most common causes being insect stings, meds, or food allergies. Has anyone ever seen the videos of people giving their babies like peanut butter for the first time in the ER parking lot? Has anyone ever seen that or heard of that? I was actually just watching a podcast last night with an allergist, and he was saying it's not usually the first interaction that's the problem. It's the second, third, or he said up to even the 1,000th, because people develop allergies kind of randomly. So if they're giving them food, especially if we're talking that 6-month age where they start introducing solid foods, you never really know what they're allergic to, but don't anticipate it to be the first one every single time. Oftentimes their body needs an exposure. Their body needs to decide, I don't like that. If you give it to me again, I'm gonna kill you, right? And then we mess around and find out, for lack of better terms. So anaphylaxis, we have the hypoperfusion, right? So blood pressure's dropping, pale skin, maybe mottling. Stridor, wheezing, as we hear that upper airway swelling, right? Getting narrower. Increased work of breathing, which can look like retractions, accessory muscle, tripod, nasal flaring, all the things. They might be restless, agitated, and sometimes they're gonna have a sense of impending doom. What does impending doom mean? Someone has a sense of impending doom. They say they're gonna die. And if someone says, I think I'm gonna die, believe them, because they know their body better than you do. And in my experience, they tend to be right, so. And then hives, remember with hives, it's not always obvious on the neck, arms, hands, check the chest. I'll get you. Check the chest, check the abdomen. That's gonna be a good spot to check. Make sure we're not missing. Yeah.
So sense of impending doom in relation to children, how might that look differently? Or are they just as accurate going, I'm gonna die, or are they just freaking out?
It's a hard line to walk, right? They're gonna be saying things like, am I gonna die? I think I'm gonna die, depending on the child, right? Like it just depends on the circumstance. But as far as I know, it's like I haven't had, thankfully, too many involvement with impending doom with kids, but I would imagine it's somewhere along the same lines. Yeah, I can't give you too much personal on that one, fortunately, unfortunately. Okay, so treatment of anaphylaxis, airway, oxygen, right? Make sure that ABC is intact. The caregiver, allow them to assist in positioning the patient. I've had to have mom and dad help hold down kids so I can give an IM epi shot before. Use your resources around you, okay? And then keep the calm. If they have an EpiPen, remember we can use their EpiPen if we have to. If time is of the essence and we need to get epi now, definitely use their EpiPen, okay? And then provide rapid transport. This is one where I've had a few pediatric anaphylaxis calls. One that immediately comes to mind was a kiddo who was allergic to eggs, and mom and I think it was her sister or friend or whoever, they went to Chick-fil-A before. They got a Cobb salad, asked for no eggs. Whoever had made their food didn't change gloves between touching the eggs and making the rest of it. Kiddo ended up going into anaphylaxis. So sometimes you'll know the answer pretty straight out. Other times you're gonna be projecting a little bit. Just keep that in mind. Questions on pediatric shock. Do kids compensate for as long as adults do? Do they compensate better when they can? Yes. Okay, good. All right. Bleeding disorders, this is obviously not one that you can look at someone and be like, that guy's a hemophiliac, right? You're just not gonna know. This is gonna be one of those things, history is gonna help. So hemophilia, congenital condition where the patient lacks normal clotting factors. There's several other clotting factors in our blood and they are missing, I think it was clotting factor 9. Don't quote me on that one. But most forms are hereditary. Anytime someone's a hemophiliac, it's gonna be severe, okay? Hemophilia, even things like a paper cut or a nosebleed are genuine life threats to these people. It's because they can't clot off and stop the bleeding. Predominantly found in males. Reason being is because it's an X-transmitted disease. So if we're talking XX and XY, male and female chromosome setups, if a mother's a carrier and then dad is not, and he provides an X, they're having a daughter, the daughter will not have hemophilia. She'll have one of her X genes is gonna have the hemophiliac gene, but the other one doesn't, so she's a carrier. If it's mom provides the X, she's a carrier, dad provides a Y, it's a male, their only X gene has the hemophiliac gene on it, they are gonna be hemophiliacs. So not to say it can't happen with women, it just has to be the right setup. Dad has to be a hemophiliac, mom has to be a carrier, okay? Bleeding can occur spontaneously. It depends on the vasculature, depends on how weak or strong that vasculature is. And then all injuries will become serious because once again, blood does not clot. Questions on this one? Now this is just one of many types of bleeding disorders. There's so many out there we're not actually gonna get into. A lot of them are fairly rare, but they do exist. So make sure you're getting a good history and they'll fill you in. And if it's something where like, oh, they have May-Hagelin anomaly, right? You can ask them, well, what is that? And then allow the parents to fill you in. Because remember, if their kid has it, they're likely a better topic expert on it than you will be, okay? Just because they've been dealing with it for longer periods of time. Okay, so altered mental status, AEIOU tips still applies. Okay, so remember, if you're unsure, we have an altered mental status patient and you don't know where to start, there's nothing obvious screaming at you what it is, run through that list, okay? It's a good one to have back pocket. Now, abnormal neurological state, so understanding developmental changes and listening to caregivers' opinions are important, right? We know that kids are they're gonna present a little bit differently, typically, than most adults, right? Depending on their level of cognition, depending on their level of development. You know, a kid could be saying something that's just totally out there, and it's like, is this normally like this? Use mom and dad, right? Because if they're like, oh, that's weird even for them, that might be a sign, okay, altered mental status is setting in. So signs and symptoms are gonna vary, right? Anywhere from confusion to coma. This is unfortunately a very broad spectrum of things. I can't tell you you're gonna see one thing or the other every single time. End of the day though, still ABC management, still transporting. Nothing crazy changes on our end. Questions on that at all? So I saw seizures is next. What is the type of seizure that kids will get that adults typically do not? Febrile, yeah. Now when it comes to febrile seizures, does it depend on how high the temperature is or the speed of getting a temperature or getting a fever? Speed, right? That speed of change is going to be the big factor when we're talking febrile seizures. If they go from 98 to 103 over the course of 2 minutes or a minute, it's one of those things where seizures have a high likelihood, typically febrile. So seizures, remember, once again, are like lightning storms in our head. Instead of the coordinated electrical activity that our brain normally keeps, it's going to be everywhere. Okay, so it manifests differently. Remember, there's tonic, clonic, general, or grand mal. Those all mean the same thing, tonic, clonic, general, or grand mal. The reason I go over that is because the NREMT loves to throw one or all three of those definitions at you. They all mean the same thing, okay? Now, subtle in infants with an abnormal gaze, sucking, and or bicycling motion, so their legs will start doing this, right? Not every seizure is going to be the lock up and start shaking, so they could have some abnormal presentations there. More obvious in older children, that's when we'll get that muscle contraction, the seizure we are all thinking about, okay? And then obviously consciousness is going to be, or unresponsiveness is gonna set in. Okay, so some common causes, I'll let you flick through that on your own. So once the seizure stops and relaxes, once again referred to as the post-ictal state. Are they super with it in the post-ictal state? No. Okay, it's tougher with kids too, because once again, is this a normal presentation or not? Now, the longer and more intense the seizure, the longer it will take for them to correct themselves as far as the imbalance in their brain. So it could last a longer time. Okay, and then post-ictal state's over once they're in a normal level of consciousness. This looks different depending on the kid. My neighbor, long before I lived where I live now, I met him. He's a known epileptic to us. He will seize, his mom's really dialed in on everything. I've had several conversations with her about this. Pretty dialed in with her medications and what she needs to administer and when she'll call us. But she pointed out something to me very early on when we first met, unfortunately over her son having a seizure, that I never really thought of. Check their watches. A lot of kids or parents of kids who have diseases like this or issues like this will put their medical history in their smartwatch because a lot of them don't have phones. Right? So for him, if you check his medical history in his watch, it tells you known epileptic and it tells his average length of time he's post-ictal. It also tells you that he fights when he comes out of it. And I can confirm when he's coming out of his post-ictal state, he gets aggressive and angry, starts pulling things off his face, pulling IVs out his arm. Every presentation is a little different. Okay, but double check that. It's a great resource. If you're someone who has not filled out your own medical ID in your phone, it's not a bad idea. Okay, because a lot of us out in the field will use that if we can get into it. Now seizures, if they go untreated, depending, there's a couple of variations. Both of them will land at status epilepticus, maintain seizure activity. So if it's a prolonged seizure lasting longer than 30 minutes, status epilepticus. Or if they seize, stop seizing, post-ictal, seize, stop seizing, post-ictal, seize, stop seizing, post-ictal, that repetitive without ever coming into a full cognition mode, they will also be deemed status epilepticus. So prolonged seizure activity there, okay? The longer that seizure goes, the more life-threatening it becomes, because are we breathing very well when we seize? No. So remember, we can positively ventilate, provide BVM breaths to these folks. If the patient does not regain consciousness or continues to seize, protect their airway and protect themselves from harming themselves. So, should we hold their head rigid? No. Why not? I saw you shake your head. Why not?
Oh, that would damage their spine.
Yeah, potential damage to the neck or spine. Very good. Yeah, we're going to turn them on their side. That way we can manage the airway. If they start vomiting it to the floor, we can suction and then cradle the head, okay? For a long time, seizures, they told everyone to put something in their mouth, like their wallet or something, like a belt. Don't do that. All you're doing is creating another airway obstruction, okay? Very good. There's something else, but it's gone. Okay, so management, we kind of talked about it. Secure and protect the airway, that's priority. Got to make sure they're breathing. Oh, I remember. What are the things we use for fuel? What do our cells use for fuel? There's two big ones. Someone tell me the first one. What do our cells? Glucose, and the other one? Oxygen. So if we have excessive muscle usage, what do you think their BG is going to look like? It's probably going to be low, right? Because they're burning through all their sugars. So make sure you're double checking a BG on these kids. Be better than I am. I had one call in particular for a known epileptic. When we were leaving, there's a whole story I'm not gonna get into. As we were leaving, fire asked me, do you wanna get a BG? And I was like, I'll get one in the ambulance, I'm not worried about it. Should have worried about it, because as we're pulling into St. Al's, I finally got to that BG, it was 40. And I could have corrected that a lot sooner, right? So the reason I'm telling you that is I'm owning my mistakes and trying to get you guys to be better than I am. So double check that BG every time you have a seizure patient, just as a rule out. That way we make sure we're covering all of our bases, okay? So back to management. So secure, protect the airway, right? So position the head, open airway, clear the mouth with suction on their side, okay? The recovery position, and then 100% oxygen, okay? Either non-rebreather or blow-by, either one will work. And if we have to, if there's no signs of improvement, we can start using the BVM, okay? Questions on any of this? Okay. So some caregivers will also give their children a rectal dose of diazepam, diastat, prior to your arrival. So when I was saying my neighbor, the order of events in their household goes, when he seizes, and he seizes twice a week, pretty average. When he seizes, she'll wait 10 minutes or so to see if he breaks it by that point. If he does not, she will administer rectal diazepam. If after 5 more minutes that's not breaking the seizure, that's when she will call us. Okay, so these people who deal with seizures on a routine basis have a pretty set step-by-step plan. Okay, so try to get the order of operations pretty quickly. It doesn't mean much for you as EMTs, but if I show up as a medic and they've already given diazepam, I can't give an immediate dose. I gotta wait. Okay, so that's just things to consider. And then transport to the appropriate facility. Questions at all on this? Okay. Meningitis, kind of talked about it, right? Inflammation of the meninges. Remember, the meninges are the layers around our nervous system. So dura mater, pia mater, and the arachnoid mater, or arachnoid space in between, okay? But inflammation of the tissues that cover the spinal cord and brain can be caused by several different variations, bacterial, fungi, parasites. If left untreated, can lead to brain damage and up to death. And then being able to recognize meningitis is important. So stiff neck, headache, fever, that's a pretty good indicator. Now let's say they're young kids, right? And they can't really vocalize those things. If they're grabbing at their head, if they're grabbing at their neck, those are good indicators that something's bothering them, okay? I had a friend, he actually works for Boise Fire now. He ended up getting meningitis when he was a kid. He got it from a spider bite. So it's out there, you never know. Now, individuals at the greatest risk of meningitis, and when we say greatest risk, we're talking about with complication, okay? So males, newborn infants, those with compromised immune systems. There's a lot of reasons to be immunocompromised besides AIDS or cancer, just throwing that out there, okay? History of brain, spinal cord, back injuries, if they've had head trauma, right? Anything that can cause bleeding or swelling. If they have shunts, pins, or foreign bodies in their brain or spinal cord. Shunts are not uncommon for the kids. It's basically a redirect of CSF. There's something going on where that normal pathway of cerebrospinal fluid flowing is disrupted. So they'll put like a little tube in their brain or around their brain to keep that CSF flowing normally, Okay, but that should be an indicator of something going on with that shunt, right? We can ask questions around what's already going on. So signs and symptoms will vary, but fever, altered level of consciousness, maybe a seizure, right? Anything neuro presents weird. Okay, now infants younger than 2 to 3 months can have apnea, cyanosis, fevers, distinct high-pitched cries or hypothermia. I couldn't tell you what that distinct high-pitched cry is. I would Google that, spend some time on it. Now, meningeal irritation and meningeal signs are often used to describe the pain that accompanies movement. So they move their neck, it hurts, right? That stiff neck, that pain. Often results characteristic stiff neck. And then in infants, increased irritability, bulging fontanelles without crying. What did I say about bulging fontanelles? What could that mean? Increased what in their head?
Fluid.
Not fluid, maybe fluid, huh? Intracranial pressure, very good. Yeah, increased pressure, which could be caused by fluid, I guess. Yeah, remember that bulging fontanelle, that is a quick sign. That's a young kid, less than a year old. The bacterium that causes it, Neisseria meningitis, rapid onset of meningitis symptoms, okay, often leads to shock and death. Neurogenic shock because ICP building because of the surrounding tissues. Now, the children present with small pinpoint cherry red dots or large purple black rashes. That's what's known as petechiae versus purpura, and I'll show you what that means. Oh, there we go, perfect. Okay, so petechiae is more of like the little red dots, like someone took a red marker. It's just putting dots on them. Purpura is where it starts to blend together. Like this would be a good example of purpura. All those dots are now forming one big mass, okay? So we could see these as skin signs potentially. Questions on these two at all? Okay. Good Lord. Okay. Which are right here. Yeah, so petechiae are the little dot ones, and then where it starts kind of clumping together, that's going to be our purpura, because purpura gets purple. That's how I always remembered it. So patients with suspected meningitis should be considered contagious. Once again, you can catch meningitis. It can be contagious. You do not want it. So standard precautions, especially once you learn of their diagnosis. Me personally, when I was out in the field, I always started my calls with just gloves on. Okay, unless I knew at baseline I was going in somewhere real sick. But I used to always keep a mask in my pocket, and I used to wear a hat all the time, so I'd keep my glasses on my hat. Just have them in case you need them, okay? Because more often than not, we don't know how sick people are until we're talking to them, okay? And at that point, we're well within range of contagious, okay? So treatment, supplemental oxygen, assist ventilations as needed, and then reassess frequently. So probably every 5, consider them unstable if we're seeing signs of meningitis, okay? Realistically, nothing we can do to fix this. They need a hospital. Okay. More often than not, they're going to go to like the ICU for management for prolonged periods as well. Okay. Questions on meningitis at all? Okay. Moving on, GI. So never take a complaint of abdominal pain lightly. Okay. Kids, yes, they throw up. Yes, they have diarrhea. But there's usually a root cause to it. Okay. So complaints of GI origin are common in peds. Ingestion of certain foods or unknown substances, especially as they're trying new foods for the first time. We don't know what they're allergic to. We don't know what's going to upset their stomach. Okay. Now, in most cases, patients will be experiencing abdominal discomfort, nausea, vomiting, diarrhea. Okay. If depending on the age, if that kid's still in diapers, mom and dad are going to be able to tell you how frequently they're going through those. Okay. I know because you change a bunch of diapers with babies. Okay. So they'll be able to tell you these things. Now, appendicitis, before we get too far, oh, it's already up there. Right lower quadrant, right? So typically presents with fever, pain in the right lower quadrant, can lead to peritonitis or shock. Remember, peritonitis is generalized abdominal pain, inflammation of that peritoneal lining of our stomach. And the rebound tenderness. Can somebody explain rebound tenderness to me? What does that mean? If we're looking for rebound tenderness.
You push into the stomach, and as you release, they feel pain.
Yeah, exactly, yeah. Right lower quadrant pain. I poke my hand in there, I pull it out. The second I pull that out, that appendix is going to slap up against their inside of their abdominal lining, and it's going to cause them to double over in some pretty extreme pain. Now, for me personally, I was not big on rebound tenderness Because realistically, if I walk into a room and they say right lower quadrant pain, I'm already thinking appendicitis before I even touch this person. It's a confirming sign. It can help really nail down what you think. But realistically, if you heard right lower quadrant pain without checking rebound tenderness, is that going to change your treatment at all? Probably not. Probably going to manage, get them to a hospital, right? Now, I'm not trying to dissuade you from using it, but I am telling you is to be your own provider. Okay, if you want to use it, feel free. If you don't want to, don't. But figure it out, okay? You're gonna have to kind of reflect on that one. Now, if we suspect appendicitis, promptly transport to the hospital for evaluation. Okay, so here's another thing. If we're transporting someone, right lower quadrant pain, we use rebound tenderness, confirmed, I think it's appendicitis. And halfway through my transport, they go, oh, the pain stops, I feel a lot better. What do you think that means? It bursts. Yeah, we gotta drive faster. It's hard for something to hurt if it doesn't exist anymore, right? So obtain a thorough history from the primary caregiver. Once again, how many wet diapers? Is child tolerating liquids, keeping them down? How many times have they had diarrhea? For how long? When they're crying, are they tearing? Now, I think personally, these are great. These three, diarrhea is diarrhea. But these three, first two and the last one, are great questions to ask generally, right? Because if they're going through less diapers a day, when they cry, there's no tears. What does that probably mean the kid is at baseline? If they don't have any fluids. What does it mean?
Dehydrated.
They're dehydrated. Yeah, they're probably dehydrated. So we already know we need to get involved. We already know there's things we need to pay attention to, right? Because we know with dehydration comes fluid problems with pressure, right? So we could start seeing systematic changes. Another thing with GI, because we're talking peds, that's upwards to 18. What are we assuming of any female of childbearing age with abdominal pain? Yep, pregnancy, right? Because the last thing we want to do is miss an ectopic pregnancy, because ectopic pregnancies are life threats for both mother and fetus, which fetus is more than likely not going to make it. Just the realism. There's not enough space for that fetus to grow. Good. Okay, so poisoning, emergency management. I know some people already at poison control thing. I know Kylie was big on that. If you don't have poison control on your phone, definitely put it in your phone. I used it a few times. It's something that they're gonna have a lot quicker access to, a lot more thorough information than what you'll find on a Google, okay? So, common among children, can occur by ingesting, inhaling, injecting, or absorbing, right? So touching the wrong substances. Common sources: alcohol, aspirin, cosmetics, household cleaning products, houseplants, okay? Big long list of things: iron, meds, extracurricular drugs as I call them, vitamins. Signs and symptoms can vary, right? Just depending on what they got into, it's gonna dictate what we're seeing. So keep that in mind. It's not always gonna be the same across the board. Also be alert for signs of abuse, right? Is there a reason, or not reason, is this something where they accidentally got into the medicine cabinet, or are you leaving things out, people leaving things out nonchalantly and then kids are getting into it, right? Because then you have a case for CPS type things, okay? After the primary assessment, things to ask the caregiver: what's the substance they got into? Do you know? Do you know how much they got into? When did this happen? How are they acting? Are they acting normal or abnormal? Okay. Did they cough, choke once they got exposure to it? Right? That's more so information for us to gather so we can tell, we can call poison control and they can tell us, so we can tell doctors and nurses when we get to the hospital. Okay. Contact poison control. So our treatment: external decon, right? If it's a powder, we're gonna brush it all off and then irrigate the area for about 15, 20 minutes. You can obviously do that in the ambulance if time is of the, well, maybe not that part. Yeah, don't decon in the ambulance, just kidding. That was bad advice. But some things, right, if we've already deconned them, we can do a lot of our treatments en route as we get moving, okay? If it's a fluid that's on them, we're just gonna irrigate the area. Okay, so assess and maintain ABCs. Be ready to treat for shock. And then activated charcoal, not common anymore. That was one that was really common for a while. We just don't give it as often as we thought. So don't be surprised if you guys don't have activated charcoal on your ambulance or in your fire engine stuff. For dehydration, remember, anytime we're losing more fluid than we're taking in, so excessive urination, diarrhea, vomiting, all could lead to hypovolemia. We could be hypovolemic because of the fluids. Okay, so vomiting, diarrhea, talked about it. Infants and children are at the greatest risk, and the reason they're at the greatest risk is because that's starting to affect circulation. And once again, they have to have a high cellular demand, so they need that blood circulating. If we're losing fluids, we're losing fluid in our blood. Okay, and then can range mild, moderate to severe. So with mild dehydration, dry lips, gums, decreased saliva, less wet diapers. All questions to ask mom and dad. For moderate, sunken eyes, sleepiness, irritability, loose skin, which we'll talk about. It's called turgor. If you pinch the back of your hand and it stays tented up, you're probably dehydrated, fun facts. Sunken fontanelles. And then for severe dehydration, they're gonna be mottling because now they're shunting blood. They're cool clammy because once again, shunting blood. They're gonna have delayed CRT. What is that? What's CRT? If we pinch our finger, what are we looking for?
Cap refill.
Cap refill time, yeah, cap refill. Or increased respirations. This is one of my favorite pictures because it really outlines this, also because that kid's skin's really far off his head. But yeah, this is a sign of dehydration. The skin turgor is poor. His elasticity of his skin is going down. Okay, so ABCs, vital signs. If you need to, get ALS en route, we can get an IV, start reconstituting some fluids, and then once again, transport to the ED. They're gonna need prolonged management. Questions at all on dehydration? Questions at all on this kid's crazy head? Okay, you guys really took that one in stride. Impressed. Okay, so fevers, right? So an increase in body temperature, 100.4 is high, right? Or higher is abnormal. Rarely life-threatening. I want to get this across now too. There's no such thing as a low-grade fever. If they're like, oh, they have a low-grade fever of 99, they just have an elevated temperature, but it's not considered a fever until it's 100.4 or higher. Okay, so causes, infection, status epilepticus, cancer, drug ingestion, all sorts of reasons to have fevers. Generally being sick. Okay, arthritis, probably not likely in kids. Systemic lupus, right? That's a immune system issue. Or if it's hot outside, right? If it's hot outside and kids are not wearing a lot of clothes, so they're getting a lot of sun exposure, that can lead to fevers. Excuse me. And then it's a result of the internal body mechanism generating heat, right? So when we get a fever, what we're trying to do, what our body is trying to do, is raise our body temperature so high that whatever the virus or bacteria or whatever's in there basically can't survive, can't thrive. For those of you who have taken chemistry before, we're trying to denature them, trying to make it so they don't work as well as they once did. Okay? Now, accurate body temperature is important for peds, right? So this is gonna be the chance for us to do a rectal temp. Okay, so you're gonna put a thermometer up the rectum. Rectal temperature is most accurate for infants and toddlers. Now, if they're older, under the tongue or under the arm will work. Does anyone know how to tell the difference between a rectal thermometer and an oral thermometer? It's the taste. But the second one is going to be the rectals are red, orals are blue. Okay. Once again, don't be like me. I once put a rectal thermometer in somebody's mouth. Ooh. But it had the case on it, so we're fine. Also, this lady had like 3 teeth in her head and they're all rotting out. So I'm not positive, but I'm pretty sure it's not the worst thing she's put in there. Just keep that in mind. Okay, so patients may present with signs of respiratory distress, shock, stiff neck, rash, hot skin, flushed cheeks, and in infants, once again, bulging fontanelles because the pressures are starting to change. Okay, as far as our treatment goes, nothing really changes. Management, transport, ABCs. Questions at all on this? Okay, so kind of talked about it, but febrile seizures, 6 months to 6 years. The oldest I've heard of is about 8 having a febrile seizure. But this is isolated to being caused strictly by the fever. This is not an epileptic thing. This is not a congenital thing. There are people who have had febrile seizures as a child and never seized again in their life. Okay, they're kind of, I don't want to say one-offs, but if they've had them, they can have them again because of the fever, but not likely to be something that prolongs through life. Okay, so it typically occurs the first day of the febrile illness. Once again, it's not the height of the temperature, it's the speed to which they get there. Characterized by tonic-clonic movement. Tonic is the locking up, clonic is shaking, okay, which is most of your grand mal. Usually lasts 15 minutes or less. And the big difference is with febrile seizures is there's no postictal state, okay? No postictal state for febrile seizures, which is why it's another indicator that it doesn't tend to have neurologic deficit, prolonged deficit anyway. Maybe a sign of more serious problem though. Yeah, if they're having a febrile seizure, they're clearly sick. There's a reason they have a fever. We just got to get them to the right place to find out what. Now, assess the ABCs, cooling measures. We can use tepid water. What's tepid mean? Oh, you got a question, Sam?
I was wondering, like, so since there is no post-oppositical state, is that just because, like, there's no, like, electrical activity that's happening?
It's not the result of an abnormal electrical activity. Yeah, so like it wasn't affecting it affected the whole brain, but it wasn't prolonged exposure, if that makes sense. So that's why they tend not to have that postictal. Yeah, any other questions? That's a good one. Okay. So, yeah, cooling measure, what's tepid mean?
About 70 degrees or something.
Yeah, like room temperature, right? So we can use room temperature water, try and bring them down to a more normal temp. We don't want to just drop them into really cold water because that'll cause them to vasovagal. They'll start to bear down. You'll see pressure drops, pulse drops, all the things, okay? Now, all patients with febrile seizures must be seen in a hospital setting. They need to go, right? Because clearly there's some sort of underlying condition that's causing the seizure, or the fever in the first place. So we got to pay attention to what that is. Questions? Okay. Second most common cause of unintentional death is drowning. Okay, so obviously the big issue is they don't have oxygen, they've been underwater. Depending on the temperature of the water, we could start to see signs and symptoms of hypothermia. Okay, and then diving increased risk of neck and spine injuries, which makes sense, right? Kids diving into a 3-foot pool, cracking their head on the bottom of the pool, head and spine injuries follow. Yeah, very good. Cool, signs and symptoms. So coughing, choking, airway obstruction, difficulty breathing, altered mental status, seizure activity, all of the things that could happen when our brain becomes hypoxic, so unresponsiveness. Pulses can range depending on the temperature. If it's cold water, expect a slow pulse, okay? But pale cyanotic skin, abdominal distension. Now the big one, ABCs. These kids are gonna need quite a bit of airway and breathing management, okay? A lot of oxygenation. Don't be surprised if even after the kid seems okay, they start to kind of decline again. Okay, they still have excess fluid in their lungs. We need to ventilate, okay? Administer oxygen, apply a cervical collar if we're worried about trauma, and then CPR as we move into it. Did Kylie show a video with the foam from drowning? Someone ever seen somebody drown? I don't know why I did that in quotes. Okay, so kind of a thing they don't show in the movies. I'm gonna show you a video. I'm gonna mute the sound. That's the one. I'm gonna mute the sound on it because it's all screaming in Indian and or Farsi, and no one's gonna understand. So they don't talk about it, they don't show it in movies, but when people drown, they actually have a constant stream of foam coming out of their body, out of their mouth, out of their nose. What this foam is, it's a fluid called surfactant. So surfactant lives in our alveoli, and its whole job is to keep our alveoli open via surface tension. Well, if we get fluid in there, it starts to wash it out. Now the kicker is you will never suction that foam out. You will never get it out. They will die long before you can suction that out. So the first thing we're gonna do is give breaths, okay? Now I'm gonna show you the video. You're gonna see a couple of nasty feet, just because they're not wearing shoes. But you're gonna see the foam, okay? And I believe it's a mother, and I think her son is the one that drowned, so it'll get clearer on him. But you see that white already on his face? That's that surfactant foam. Told you there's the nasty feet. Moving on. They also do CPR in ways we're not gonna do CPR. Yeah, don't do this. That's a red flag. But you see how it's just a constant stream? You'll never be able to suction this out. You will not be able to get it. So the first thing you're bagging is through the foam. See how she continues to try and wipe it, and it just continues to come out. And now they're doing compressions, right? So every time they press, more foam comes forward, right? Everyone see the foam that I was talking about, right? It's a pretty intense thing, and it's one of those things that I want you guys to be able to recognize quickly, because I was not informed of that when I was even in medic school. It wasn't until I was Ada County and we did trainings on this annually that I saw this video for the first time, okay? It is going to be jarring, and I want you guys to be able to recognize and understand we got to do some stuff pretty quickly. Okay? Questions on that at all? Yeah.
Is it always that much?
It's all of the surfactant in their lungs going to keep coming out. Yeah.
If that's keeping their lungs open, and are they able to be revived?
So based on the training I did a few years ago, if you can ventilate that back down in there, they need that surfactant in their alveoli. So you're actually doing them a favor by venting it down because it's going to help keep those popped open. And if the better those are popped open, the higher likelihood of resuscitation. Yeah, kind of that answer your question? Yeah. Cool. Any other questions? Alrighty. Let's keep this gravy train rolling. So, trauma, #1 killer of kids in the US. Okay, so quality of care can impact recovery. Obviously, the better our surgeons, the better our treatment while we have a traumatic injury, the better our outcome will be. Now, the muscles and bones of children continue to grow well into adolescence via those growth plates. Also depends on the person. Some people will hit their adult height in the 8th grade. Some people will grow well into their 20s. It just depends. Okay. Now, another thing, fractures of the femur are fairly rare in kids. And honestly, it should be a red flag that something weird's going on. Okay, older children and adolescents are, however, prone to long bone breaking. So humerus, femur, not uncommon. It should be a red flag. I had one call in particular with a 1-year-old with a broken femur. And there were a lot of red flags raised from who the mother was. The child in the paperwork said foster care, so I had to confirm mother or not. Mother seemed to be a little disinterested by the whole thing. I knew it was a femur fracture because we picked him up from a pediatric clinic. But then you could tell there's signs that a kid's not being well taken care of, and we'll talk about him. But he was dirty, his nails were long and dirty underneath, kind of unkempt, he smelled bad, he wasn't being taken care of very well. But the biggest red flag was that when we asked mom, hey, do you want to go to the hospital with us via ambulance? We're gonna need somebody with us. She said, nah, I'll meet you guys there later. If my daughter broke her femur, I'm for sure gonna be in the back of that ambulance, right? So kind of trust your gut. If something feels off, especially femur fractures in little kids, it probably is. Okay, her story was that their 4-year-old tried to lift him up and out of the crib. And I asked how tall the crib was, and she said about this high. So how is that kid grabbing that kid from the bottom, right? Stories didn't make sense. Make sure you're doing your due diligence and being thorough with your assessment. Okay. So kind of just some quick physical stuff, we talked about it, but children are smaller than adults. Locations and injuries may be different, right? Just depending. Remember things like the abdomen, for example, the likelihood of multi-organ involvement's not, there's higher, it's not 0 ever, right? Their bones and soft tissues are less developed. So their internal armor, their skeleton is not as strong, right? So force can be transferred a lot easier through these softer tissues. So keep that in mind. Psychologically, depending on the age, once again, often injured because of underdeveloped judgment and lack of experience. Kids tend to hurt themselves traumatically because they're in that exploration phase. They're in that I'm indestructible or I'm invincible phase. Right? Once again, don't judge. We all got our stuff that made us who we are today by doing stupid things. And then always assume the child has a serious head and neck injury if there's like any sort of high mechanism. Right? Because remember, once again, kids are top heavy. They fall on their head a lot. So the likelihood of a head injury or a neck injury is not 0 ever. Okay? Questions at all on those two things? I know it feels like I'm kicking a dead horse, but we'll keep moving. Okay, so injury patterns. So the exact area struck depends on the child's height and final position of the bumper on impact, right? A taller kid getting hit by a car is not going to have the same impact as a shorter kid getting hit by a car. Right? Just depends on where that bumper hits them and where it lands. But typically we'll sustain high energy injuries to the head, spine, abdomen, pelvis, or legs. Well, we know the pelvis and legs on top of, head and spine, obvious for reasons if they're damaged. Excuse me. But pelvis and legs we got to keep in mind because that's a hypovolemia threat as well. Remember, we can lose a lot of blood, in adults, about 1 liter per femur and 1.5 liters to 2 liters in the pelvis. Okay, so we can lose a significant amount of blood just from those two sets of bones alone. Okay, now often we're going to see these in sports-related injuries. Kids play sports, right? So not an uncommon finding if it's athletically involved, but often injured in organized sports, head and neck injuries, especially in contact, right? So football, any sport where there's contact, right? But football being the big one here. And then always immobilize the spine. I feel like this is pretty straightforward. Nothing changes with our adult treatment of sorts other than how we're going to assess the kid, right? Head to foot, or excuse me, foot to head versus head to foot, depending on the age. Okay, so for head injuries, common in children because of the size of their head in relation to their body, top heavy. Now, infant has a softer, thinner skull, so the likelihood of brain injury is higher, okay? And that's not even including things like secondary hypoxia because of bleeding or blood on the brain. Okay, the scalp and the facial tissues may cause a great deal of blood loss as well if not controlled. Remember, our face and our head have a lot of vasculature, so if they rupture, they get cut, they're gonna bleed a lot, okay? Nausea, vomiting, common signs and symptoms of head injury in children. Easy to mistake abdominal injury or illness, right? If kids starting to throw up, you're gonna think it's something that has to do with their bowel, right? But that's where we gotta ask questions. They hit their head, were they unconscious, right? There's so many other questions we can ask. And then suspect serious head injury in any child who experiences nausea, vomiting after a traumatic event, right where I was going with it. So we still need to immobilize them, right? We're still gonna log roll, we're still gonna put a collar on, we're still gonna manually stabilize, okay? Can be difficult because of proportions. You're just gonna have to make it work, okay? We do have the equipment set up for it, though. We do have pediatric collars and things like that. And then younger children are gonna require padding under the torso. Remember, under the shoulders, maintain that open airway, because if they have the big head, they're gonna be like this, and that's a hard airway to manage, okay? And then we might need to immobilize them in a car seat. That's gonna be a lot of padding. That's one where you're gonna get creative, okay? Check your protocols, wherever you're at, hopefully they train you up on that. Now, chest injuries, usually the result of blunt trauma. Once again, kids have more fragile rib cage. They have a smaller rib cage. So the likelihood of flail chest segments is pretty high too, okay? Maybe injuries within the chest as well, right? If there's enough force to break a segment of ribs, there's definitely enough force transfer to start affecting lungs, heart, underlying tissues, okay? And then we're gonna manage the exact same way, right? We're not gonna put anything on there like they used to back in the day. You're just gonna oxygenate, manage the airway, ABC stuff. Let me get through these and we're gonna take a short break. It'll be a 5-minute break and then we'll finish out strong, okay? So abdominal injuries common in children, can compensate for blood loss better than adults, like we talked about, right? They shunt from their skin. Children with have a serious injury without early external evidence of a problem, right? So it can be a prolonged thing. If it's something like a ruptured gallbladder, ruptured stomach, it's gonna take some time for that to start showing up. Watch for signs of shock. And then once again, our shock treatment remains the same. Supine, maybe legs up, Trendelenburg. Cover with the blanket, heat the ambulance, give them oxygen, drive. Yeah, so remember kids have less blood. So they don't need to lose as much blood as an adult to start entering into shock. They don't have as much to give. So if they start losing 25% to a child is much different than 25% to an adult because they have less blood volume typically. Does that make sense? Okay. Burns, considered more severe or more serious than burns to adults. Remember their rule of nines is different. So they will lose higher percentages a lot quicker. Have more surface area to relative body mass, which means greater fluid and heat loss. They don't tolerate the burns as well, meaning that this is one because they're already poorly insulated, right? They have less adipose. Those burns tend to be more severe fairly quickly. And then more likely to go into shock, develop hypothermia, and experience airway problems, all based on burns, okay? Because of the fluid, and then the airway, because kids panic and they take that breath, and if they're around fire or something that is hot, they can breathe that in, and now we have airway damage as well. So common ways that children will be burned: exposure to hot substances, hot items on a stove, exposure to caustic substances, right? Touching something acidic they shouldn't be touching. Infection's the big one with kids. Kids definitely do not maintain as well. So burned skin cannot resist infection as effectively, and that's everybody, but kids in particular, because of the surface area, have a higher likelihood just because more skin is burned, okay? And then always sterile techniques, so fresh gloves, making sure we're keeping, do we use wet or dry dressings for burns? Wet or dry? Someone holler me a guess at least. No, we're gonna use dry. So the reason we don't use wet is if we can't control the temperature of that saline, so if that saline's cold and we put it on them, they're gonna get colder quicker. We always use dry, also because wet brings one of the components needed for infection. okay? And pro tip for anybody that has a severe hand burn, make sure you put gauze between their fingers, because the last thing you want them to do is get stuck together, okay? Because that's gonna be real problematic. It's gonna suck taking the dry dressings off anyway, but the hospital is gonna have to debride it anyway. They're gonna have to go and clean the wound as is, so don't worry about it. They're gonna let them down and remove them and get the kid treatment as needed. Now, certain situations we will consider to be abuse, okay? So consider child abuse in any burn situation. Make sure you get the full story, okay? And report the findings. Remember, we report to doctors and police, and then the burns can range, right? Minor, moderate, or critical, just depending. So we will talk more about abuse. There's a whole bunch on this. So pediatric patients are managed the same manner as adults. So we're gonna prevent hypothermia, cover them with a blanket, keep the ambulance warm. If they're starting to show bradycardia, ventilate, oxygen fixes our heart rate, and then monitor during transport. Questions at all on burns with kids? I would really advise you to spend time on the rule of 9s for kids. Okay, so injuries to extremities. Children have immature bones with active growth plates like we've touched on. So growth of long bones occur from the end of the specialized growth plates, which make them potential weak spots, okay, because that bone is volatile and changing. So we have those incomplete or green stick fracture types that will start to show up. Now, generally, extremity injuries in children are managed the same as adults. We're just gonna splint, right? Splint, get everything organized. Remember, if it's a broken bone, we gotta secure the joints above and below. If it's a broken joint, and including the bone. If it's a broken joint, bone above, bone below, including the joint, okay? Even if it's deformed, splint it in place. And some of these are gonna be more common in kids. Like a very common fracture type in kids' arms is that spiral fracture, because someone, like parent grabs their arm and pulls them, and then they twist their arm, they can actually fracture that way. But pain management, if the kid can't give you a number because of age, you can use the faces on those scales. Now, as far as realistically our interventions, splint in place, ice, right? Try and make them as comfortable as you can. Maybe elevate the extremity to bring swelling out. ALS can get involved, so we can give pain medication. And then another important tool is kindness and emotional support. These kids are gonna be scared, they're gonna be pretty upset. Being a patient advocate and building good rapport and being kind to these kids is gonna go a long way. They're not gonna remember the broken arm entirely, but they're gonna remember how you treated them and who they talked to. Okay, let's take a 5-minute break. Let's come back at 4:12. So I am actually going to skip past disaster management for time-saving stuff. But start triage is where the majority of us are gonna use, or what the majority of us are gonna use in mass casualty type situations. So spend some time in it, look through it. There is kind of a step-by-step. Okay, so important topic. Gotta bring the temperature of the room down a little bit, but child abuse and neglect. So any improper or excessive action that injures or otherwise harms a child. So it can be physical, sexual, neglect. You can have emotional abuse, just kind of across that spectrum there. Over 500,000 children are victims of child abuse annually, with many of them suffering life-threatening injuries. I would even include, if not life-threatening injuries, disability injuries as well. Okay, something that could be lifelong. Deficits is what I was using. So, what are some signs? So child abuse occurs in every socioeconomic status. The wealthy abuse their children the same way, not the same, but the wealthy abuse their children, poor people abuse their children. It doesn't matter how much money that people have. People just suck sometimes, okay? So be aware of the patient's surroundings, document your findings, right? So is the place clean, or is it well kept? Does the child appear dirty, or their clothes ripped, worn, right, torn through? Little things that we can start to pick up on fairly quickly. So, things to ask. Is this injury typical for a child this age? Is the mechanism reported consistent with the injury, right? Does it make sense? Think about the story about that kid with the broken femur. 4-year-old tried to pull him out of a crib. Doesn't really add up, right? Is the caregiver behaving appropriately? I'll come back to that. Evidence of drinking or drug use. Are they delaying the seeking of care? Does it appear that the child and the caregiver have a good relationship? But caregiver behaving appropriately, right? That's gonna be a big one. I know one gal, she was a medic for a long, long time. And she ended up quitting after having a bad string of pediatric cardiac arrest calls, one of which was a shaken baby case. And when I was talking to her about it, like 3 or 4 shifts after, she was saying that the stepdad seemed really nonchalant and act like this wasn't a big deal when this is the guy that shook that baby to death. Okay, so that's red flags, right? Kind of have that high index of suspicion for a lot of these things. Are there multiple injuries at different stages of healing, right? The big indicator there is bruises, right? We all know if I get a bruise, it's going to start purple and then kind of a green color, then yellow as it dissipates out. Well, if we're seeing mixtures of yellows and purples and greens, that kid's being hit repeatedly over time. Okay, it's not just one isolated incident, more than likely. Unusual marks, bruises that could be caused by things like cigarettes, heating grates, branding injuries, holding something hot up to them. Are there several types of injuries? Are there burned hands or feet in a glove distribution? What does that mean? Can someone tell me in their own words what that means? Burns on the hands or feet in a glove-like distribution. You look like you got something. Yeah, like if somebody dips a kid's hand into a boiling hot pot of water, right? Their whole hand's encased. I mean, not to say it's impossible, but not likely, right? Not likely that a kid's gonna touch something hot and then just continue to dive their hand down. Doesn't make a lot of sense, right? Those are also, you'll even hear if you ever want to look up a gnarly injury pattern, degloving injuries where they rip the skin off. Pretty gnarly. Okay, is there unexplained decreased level of consciousness? Is the kid acting weird and they're like, I don't know, it could just be anything, right? Is the child clean? Appropriate weight for their age? Do they have any rectal or vaginal bleeding? That's abnormal, right? Talk more about it in OB, but I recently found out it's not uncommon for brand new babies to actually have menstrual-like symptoms because of the hormones from their mother. I learned that the hard way. What does the home life look like? Is it clean? Is it dirty? Is it warm? Or is it cold? Is there food? Are the lights being able to turn on? Are they paying their bills, right? These are all indicators. If they can't take care of these things, what makes you think they can take care of their child effectively, right? Not to say they're not doing a good job, but more so like if they don't have the means to take care of themselves, they don't have the means to take care of their children. And that's just kind of a harsh reality, okay? So child abuse mnemonic, if you want to go through it, I would recommend doing so. I will not stop on it. So bruises, observe color and location. Remember, new bruises are pink or red, turn blue, then green, then yellow, and then fade. Kind of like I mentioned, if we see those multiple stages of healing, that should be a red flag. Bruises to the back, butt, or face are suspicious, usually inflicted by another person, right? Most people don't slap themselves in the face hard enough, especially kids, or spank themselves hard enough where they leave bruises, okay? Not common. Burns to the penis, testicles, vagina, or buttocks, usually inflicted by someone else. This is typically hot water dipping. I've seen this one time. It was when I was in my clinical rotations for medic school. It was in the ER. The story I was listening to by mom and grandma being told was that grandma drew a bath for the kiddo, didn't check the temperature, dipped him in there, and this poor guy, he was burned everywhere below the belt. Now, the story was lining up to me in my head. I was still pretty new to this profession. The doctor saw something different. She actually ended up having it investigated, right? I would rather investigate and be wrong than miss something and that kid's now in danger, right? Burns that look like a glove, usually inflicted by someone else, right? Dipping their hands, dipping their feet in. And then suspect child abuse if child has cigarette burns or grid pattern burns, right? Hot steel or hot metal on their skin. For fractures, kind of talked about femurs already, but fractures of the humerus are also not a normal occurrence in little kids. Kiddos fall down all the time. That would be like our highest index of suspicion, maybe even falling off of something, but they tend to absorb that impact. They don't typically break those bones, okay? Falls from beds are not usually associated with fractures, right? So there's another red flag to that femur story I told you. Maintain an index of suspicion in an infant or young child sustaining a femur fracture, or if they have any complete total fractures. Because remember, kids' bones break incompletely or as a green stick, break and peel. They don't often snap clean in half. Not a common thing, red flag, okay? Shaken baby syndrome. So infants may sustain life-threatening head trauma by being shaken or struck, right? So they have less CSF cushioning their brain. They essentially just have coup contra coup injuries over and over and over. And then bleeding within the head and damage to the cervical spine, high likelihood, okay? And then these children will be found, infants will be found unconscious without any obvious signs of external trauma because they weren't being hit, right? They're being shook, maybe struck, but likely it's gonna be a shake, right? So we won't see any physical signs, but we'll see the presentation of. Questions on shaken baby at all? Yeah, not a fun topic. Neglect, so refusal or failure to provide life necessities, so water, clothing, shelter, personal hygiene, medicine, comfort, personal safety. Does the baby feel comfortable in this environment, or does the kid look comfortable in this environment? Okay, it's harsh. It's harsh, and we have to judge people sometimes based on this. I walked into one house, now granted there was no child involved, but this is where my head originally was. We walked in, found a person down unconscious on the floor, but there was like Christmas, and this is like June, Christmas ornaments thrown everywhere, toys that were broken, thrown against a wall very clearly. None of the like water or lights were working. Finally talked to this woman to get her conscious enough, and I asked her, is there a kid in this house? And she said, no. It's a long story, but the kid was out of state essentially, and that she just had a fit of rage essentially because baby daddy problems. So there was no kid involved, but those are all red flags. If I walk in there and I see that, first question, is there a kid in here? We gotta look, right? Which we did, and we didn't find anybody obviously. But you gotta double check, right? And it's not because people are necessarily doing anything super wrong, but if, once again, if they don't have the means to care for themselves, it gets harder to care for a child, okay? Not to say it's impossible by any means. Now, abused children may appear withdrawn, fearful, or hostile, right? They're acting out because of what they deal with at home. May be concerned if the child does not want to discuss how an injury happened. If you ask them what happened and they look at their caregiver all the time and they tell you something that doesn't seem to add up, it's a red flag, okay? Parent may reveal a history of accidents, right? So be alert for conflicting stories, lack of concern. When I was worried about child abuse, I would try to interview mom and dad separately. That way I could see if I could get a crisscrossing story or if things lined up. And then abuser may be a parent, caregiver, relative, or friend of the family. People suck, and it can be anybody, unfortunately. And unfortunately, the people who have access to children are the people who are closest to you. And that's just reality as well. Now, EMTs in all states, once again, are expected and are required to report suspected abuse. Okay, so most states will have special forms. For me, I would talk to the doctors. They'd have me fill out some paperwork from time to time. But supervisors are generally forbidden to interfere with reporting. So say we see a situation and our supervisor's on scene and we're like, oh, I need to report this. And they say, no, I don't think you should. They don't have the right to interfere. If you think something is wrong, we'd rather have someone look into it than be wrong and something happens to that child. Okay, and then law enforcement and CPS will determine whether there is abuse. That is above our pay grade or outside our hands. Questions on any of this at all? Okay. Sexual abuse. So children of any age and gender can be victims of sexual abuse. So high index of suspicion and often long-standing abuse by relatives, because once again, the people who have access to the children tend to be the ones who are the perpetrators, okay? Not to say it's every time, once again, but still. Assessment, limited to determine the type of dressing required, right? We're not gonna do we're gonna be thorough, but we're not gonna be, really diving into it. We're going to make sure we just take care of what we need to take care of. Treat bruises and fractures as well. And then if there's no evidence of bleeding or injuries, leave the genitalia alone, because then you're just opening yourself up for liability, okay? Now, not to say if you see, making this up, a child walking around the back of their pants is soiled with blood, that's an indicator. We might need to check some stuff, okay? Now, assessment, do not allow the child to wash, urinate, or defecate until a physician examines them. It's kind of the same idea when we talk about sexual abuse of adults, right? We got to make sure that the proper kits are done, make sure that we do DNA swabs, get the evidence if there is a crime, and then ensure the EMT or police officer of the same gender lines up with the child. Once again, if possible, do so to the best of your ability. It's more of a comfort thing, and it's more of a cover yourself type thing, right? Make sure you're not putting yourself into a weird potential liability type situation, okay? Maintain professional composure, so caring, concerned speech, and then shield them from onlookers. You're gonna have looky-loos all the time, people, and this is every call, you're gonna have people who wanna see what's going on, neighbors coming out into the street. Try to protect that kid's dignity, right? Especially at such a young age, you don't know what the damaging effects that could have down the road on their psyche. So obtain as much info as possible from the child and witnesses. Transport all children who are victims of sexual assault. They need to go to a hospital. they will have the proper authorities lined up from there, or they can go through the reporting system with CPS. Okay, sexual abuse, once again, is a crime. And then make sure you're cooperating with law enforcement officials in their investigations. Another thing, two things. First of all, make sure you write a really, really good chart. These are likely going to go to court, which means you're likely going to be a witness on the stand or be under deposition. Write a good chart. The next thing is the word rape. We never ever use the word rape in our charts. It is always sexual assault. Reason being, rape is a legal term, has a legal definition to it. So if you say, patient was raped by so-and-so, and you're on the stand as a witness, their lawyer's going to cross-examine you, and he's going to try and trip you up. Well, did you see them get raped? No. How do you know it's a rape? And now we might have just screwed somebody out of some legal justice, right? It's always sexual assault. We never document the word rape. It's very, very important for more reasons than one. Questions so far? Okay. So, sudden unexpected infant death. Has anyone ever heard of SIDS before? Right, pretty common thing, unfortunately, but yeah. So sudden unexplained death refers to a sudden unexpected death where the cause is not known until investigation is conducted, right? So they're gonna have to do an autopsy, they're gonna have to do what the scientists will do to figure out what went on. So one of the causes of sudden infant death is SIDS, sudden infant death syndrome, which results in death that cannot be explained by any other means. Now this is not in our EMT, but I was reading an article I thought was interesting about this, is they actually they being doctors, think they may have figured out one of the causes of SIDS. When you're falling asleep and you have that jolt dream where you wake yourself up, basically it's like a certain, I don't know if it's like an enzyme or an amino acid chain, I can't remember which one, but it's in the brain. But the kids who have SIDS, when your body does that, your respiratory rate slows down so much it's sending like hey, we're alive, right? And so that's why you jolt awake and then you go back to sleep. Well, they're finding that some of the kids who have SIDS or have died of SIDS are missing that amino acid or whatever it was up in their head. So when the respiratory rate starts to drop, their body doesn't send them that wake up alarm. And so they end up sleeping until they're respiratory depressed down to failure and so on and so forth. The cool thing about it is that it opens doors for potential vaccination for something down the road. Now I know vaccines aren't a commonly popular thing, or just not a popular thing in general as far as very divisive, but it would be an interesting thing, right? If we could potentially eradicate something like SIDS, right? You just never know. But fun facts, some of the new science. So annually, about 3,500 infants die of SIDS. Babies should be placed on their back, alone in the crib. No toys, no blankets, no bumpers. Kids don't need any of that stuff. Kids, dress them warmly. But has anyone ever seen the back of an Ada County ambulance before? It has the big old blocks that say A, B, C, alone, on their back, in the crib. Okay, those three things need to be met. That's how you keep children safe and alive. They should sleep in the same room, but not the same bed, chair, sofa as an adult. Co-sleeping is very dangerous. Every dead baby I've ever seen has been a co-sleeper. Mother rolled over, smothered the baby in their sleep, didn't wake up until things were too late. Okay, in their crib by themselves. And then breastfeeding and the use of a pacifier may also help lower the risk. Most of the time is so that they can breathe through their nose. They try to encourage babies to breathe through their nose because that's generally where they breathe best through, especially infants. Questions on SIDS or sudden unexpected death? Okay. So risk factors, mothers younger than 20. If the mother smoked during pregnancy, mother is using alcohol or illicit substances. If the child has a low birth rate, all of those run the risk of or increase the likelihood of SIDS. And remember, babies sleep all day at all times, right? So it can happen at any point of time, usually when they're sleeping. Okay, so 3 tasks. We have to look at the scene, what's going on. We now have to manage the patient. And then more so, we have to communicate and support to the family. Communicate and support the family. These are tough calls. These are calls that, the patient will suck, but the parents are gonna suck worse because they just lost a child, right? So things are volatile, people are upset. One in particular that I was on, when we showed up, child was non-viable. He was pretty gone. We then had to convince mom that we cannot we cannot do anything at this point because he's too far gone. And that's a really hard conversation to have. Okay, so you're gonna have to bolster your emotional strength a little bit, right? And read the room. Also understand sometimes I don't want to say walk away while you're talking to a patient, but sometimes if you need to get out of a room, get out of the room and let supervisor or somebody step in. Let somebody who's experienced this before step in. And once again, if this stuff starts to bother you, talk to a therapist. This job's not worth your brain, it's not worth your life, okay? It's a job. Okay, questions on any of that stuff at all? All right, patient assessment. So victims of SIDS will be pale or blue, not breathing, unresponsive. Might even see mottling once again. So some potential causes: overwhelming affection, child abuse, airway obstruction, meningitis, right? These are all potential causes of just general ailment to the child that could progress. And when they're sleeping, it's obviously hard to assess them constantly. Other causes, so accidental or intentional poisonings, hypoglycemia, right? So if their blood sugar gets too low, which low BG is hard to catch in kids. It's a tough thing to find. That's why you kind of do yourself some due diligence and make sure you check it. Okay, especially little ones. I ended up finding type 1 diabetes in a 3-year-old one time. And the only complaint mom said was she's acting more tired than normal. That could be a number of things, right? Do your due diligence, check everything, and then it's still gonna be an XABC assessment. So depending on how much time has passed, the child may show postmortem signs, so rigor, right? Rigor mortis in the jaw and the fingers. You might notice the pooling of blood, the ecchymosis in the back, okay? Those are gonna be our big signs. Obviously, lack of a heartbeat, nope, not breathing as well. If we see these signs, call medical control. If no signs of postmortem, we must start CPR. Once again, 2-person CPR, 15-2. Single rescuer CPR, 30-2. Pay special attention to any marks or bruises on the child before performing any procedures. We wanna know what was there prior versus what are we gonna leave. Because if we're gonna show up and ALS is there, there's IVs, there's intubation, there's a big slew of things we're gonna do. We wanna make sure we're not missing evidence from something else, okay? And then note them prior to your arrival, make sure you're charting them. Questions at all? Okay. Yeah, so scene assessment. Make sure you're taking a look around, right? So inspect the environment, note the condition of the scene. Where was the infant found, right? Was the infant moved? We gotta make sure of that, okay? Which I can tell you most mothers, if they find an infant not moving at all, they're gonna pick them up and they're gonna move them around themselves. So you just make sure you ask where they were when this all happened. Assessment should concentrate on signs of illness, condition of house, once again, potential abuse, signs of poor hygiene, family interaction, and then site where the infant was found. All of those will be guiding signs. Okay, so when we're talking to these people who lose a child, sudden death of an infant is devastating, okay? Obviously, it's gonna evoke a pretty strong emotional response, and that's both parents and healthcare providers, right? We see things that people are not designed to see on a regular basis. So keep that in mind. It's something that you need to really kind of check yourself with. Okay, and then allow family to express their grief. Now, there's some certain do's and don'ts, and we'll touch on them here in a moment. Now, provide the family with empathy and understanding. They may want you to initiate resuscitation efforts, okay, which may or may not conflict with your protocols, right? If that child is showing no signs of life and non-viability, have to have a hard conversation. In fact, the one that I was telling you about one of the ones where mother smothered the baby, when I showed up, fire had actually already started compressions and all the things. The kid was already rigored. He was post-mortem for sure. But they started that because family was screaming, we gotta do something, right? Which I'm not gonna fault them. I probably would have done the same thing in that exact situation. But looking back in hindsight, is this something where somebody should have stood up and said something, right? Because all we're doing is giving these people false hope that there's gonna be a good outcome. And there's not if they're post-mortem. Okay, so make sure you introduce yourself to the parents, caregivers, ask about their child's date of birth and history. You still gotta write a chart. This whole thing's gonna suck, but you gotta interview them about what was their name, what was the medical history, signs, symptoms, what was leading up to this. You have to ask the questions. And it's gonna be tough because they're probably gonna be not in the right mindset to answer those questions, but you gotta work your way through it because you still need to write a chart because it's a legal document and it's the death of a child. So it's gonna be looked on pretty harshly. Do not speculate cause of death, right? Sometimes it can be things that preclude that you're not aware of. Another thing, families should be asked whether they want to hold the child and say goodbye. That is something that they deserve that dignity at least. If they want to hold their child one last time, you give them the chance to hold their child, okay? It's not up to us to say no. Now, things that are helpful. Use the child's name. Remember this child was a person, right? Especially a person to the parents, okay? Use their name, keep it at the human level. A lot of providers I've seen, when they start getting a little jaded and burned out, they treat patients just like another piece of apparatus, right? That's not good for our psyche. It's not good for our patient's psyche. So use their name quite a bit. That's kind of good for patient care in general. Make sure you're speaking eye to eye, and then make sure you're using definitive language. Died, dead. We don't want to say passed away or gone, because once again, that implies an inkling of hope in a mind that's kind of erratic. Okay? Now, first one, I'm going to get on my high horse. Never say I know how you feel, right? Don't say I get it. I know, I get it. If you've not lost a child, you have no idea what these people are going through. Okay? You have no right to tell them you understand what they're going through. Okay? Keep it at a human level. If they want to call church members, if they want family there, sure. If you're going to give instructions, short, simple, basic, they are not going to be in the right mindset to handle a lot of conversation. They're not going to be in the right mindset to handle a lot of complex tasks. Okay? Ask if they want to hold the baby. Wrap the child in a blanket. Stay with the family as they hold it. Right? Now, that's not saying you need to be like right in their business, but give them some space, but be in the room. Okay? We want to make sure nothing weird happens behind the scenes. Now, another cruelty, and this is every code that we run, if we intubate, if we have IVs, if we have IOs, we have all these things going on, we cannot pull them out legally, right? And they might want them out. We can't. Because what that is that's proof to the coroner we did everything we could do to verify that we are following our protocols, we're doing things the correct way. It's kind of a tough thing, but it is something that we're going to have to get used to, unfortunately. Also understand everyone expresses their grief differently. Some will require intervention. I have called police to show up to these scenes. I have called crisis lines. There's one in particular called TIPS in our area here. It's kind of a traumatic incident group. They'll come and they'll show up to the scene, and these are people who are trained in mental health, so they can kind of help. They're not going to clear anything up, right? They're not going to fix anything that acutely, but it does give them a party to talk to about this, okay? A lot of things as well for caregivers is that we tend to feel like we failed this. A lot of providers that I know are very perfection oriented, and no call ever goes the way you want it to go. You got to kind of get over that in your head. It's a tough thing. It takes time. I can tell you firsthand. Okay. But yeah, as long as you're doing everything you could do in your protocol within your scope, you've done what you can do, and you got to find peace in that. It's harder, it's easier said than done, but it's something you got to get used to. Some EMS systems arrange home visits after childbirth. Did Kylie ever mention the community paramedics to you guys at all? Does that sound familiar? So community paramedics are people that are specific to mental health, but they also do like follow-ups on like our frequent flyers. If there was like a traumatic death, they'll follow up and they'll go and talk to family and kind of see how they're doing, just check in. But yeah, you're gonna need specific training. So typically the CP route is pretty unique. It does have some extra training, but that's just for the mental health stuff. That's something that we don't do very well, unfortunately. Now, child's death can be very stressful. Take time before going back to the job. I ended up taking a week off after my last dead baby call. It takes some time away, because if you can't take care of yourself mentally, what makes you think you can take care of others, right? Talk with other colleagues. Some people have been through the same thing that you're going through. Talk to them, see how they got through it. Don't just rely on alcohol and the stress relievers that are unhealthy for us, we all know. Okay, but be alert for signs of PTSD, and then consider the need for help if signs occur. Go talk to somebody. Once again, this job's not worth your life, which, fun fact, unfun fact, 2019 was the last time I looked in these stats. 2019, EMS had a 6% suicide rate comparatively amongst the entire field. At that point in time, the highest state suicide rate was 5.5% at Wyoming. I can almost guarantee you there are more first responders in this country than there are people in Wyoming. Put that math together, right? That's a lot of people inflicting harm to themselves. So make sure you take care of your mind. This is a field where your mind will be challenged. Apparent life-threatening events, moving past this. So infants who are not breathing, cyanotic, and unresponsive sometimes resume breathing and color with stimulation. This is when we get dispatched out to a lot. Get dispatched to pediatric cardiac arrest, and you'll hear the best words you'll ever hear in your life over the radio. Baby's crying, crying baby's a breathing baby. Now, from time to time, infants, newborns, they can like choke on the formula, choke on breast milk, and it can cause kind of a vasovagal response where they'll look like they're going into cardiac arrest. They will work their way out of it. Not always, right? Obviously, we still have pediatric cardiac arrest, but these do show up, and don't be surprised if you're dispatched to a code and the baby's fine. That happens from time to time, and this is something we see a lot with newer parents. Okay, now classic apparent life-threatening events characterized by distinct changes in muscle tone, choking or gagging. Okay, so they're choking on the formula milk, and then they go limp. Tends to lead to us showing up. After these events, child may appear healthy, show no signs of illness or distress. Okay, complete your careful assessment and still take them to the ED. Something weird and irregular happened. Get them to proper care so they can do follow-up treatments. Pay attention to the airway management, get a history, right? Pay attention to the environment. We're kind of amalgamating everything from this lecture so far, right? Pay attention to your surroundings, and then allow caregivers to ride in the back of the ambulance. Most minors, I'll take mom or dad in the back. If they're older, 17, 16, 17, I might have mom and dad ride in the front seat so I can have a more honest conversation with my patient, depending on the situation. Questions on ALTEs? Okay. Brief, unresolved, unexplained events. So brief changes in color, such as pale or cyanosis, choking, absent, slower, irregular breathing, decreased level of consciousness. When we get there, there's no abnormality found on assessment. Right? Once again, sometimes they have these weird events. We show up. Let's make sure we're evaluating them. I have had a couple of these where we ended up not transporting. Parents thought they could handle it, or they decided to take them in on their own. Okay, now it's not up to us to decide, oh, this is a temporary thing. We're always going to be pushing to go for transport, just to be on the safe side with everything, to make sure we're not missing anything and therefore having a poor outcome for somebody down the road. Questions?